Ladies and gentlemen, welcome to HealthTech 2025. Now, my name is Lynette and I will be your MC for today. Now, on behalf of the organizers, I'd like to thank everyone for joining us this Saturday morning. Now, I know it's pretty bright and early, but I do need to know that you're amped up and ready for our opening day. All right, I know I need the energy now, okay? As well as the speakers, they need your energy as well so that they can give it right back to you later on. So can I please get your biggest round of applause and cheers? Come on! I never hear any cheers there. One more time, right? One more time, right? Biggest round of applause and cheers, everybody! Alright, now y'all know you're all here for HealthTech, which is a HealthTech hackathon organized by NUHS Medicine, and it's back for the second year, and we're all here today to make a real-world impact where anyone can contribute, whether you're a seasoned developer or a first-time innovator. Now, before we start the session, I'd just like to go through some house rules. Hold on. Okay, so just some house rules to take note of. Firstly, please take note of the fire escape route. So this will be the fire escape route. Okay, don't rely on me because I don't really know where it is. I'm just going to follow you guys. Okay, so do take note. Okay, just hope and pray that there's no fire. All right. Back to the house rules. Okay, secondly, please make sure all your phones are to be on silent mode or turned off to ensure minimal disruptions during the sessions. If you do need to take any phone calls, please take them outside the auditorium. Now, thirdly, please make sure to return your lanyards as well as your name tags at the registration tables. And lastly, make sure to join the HealthTech Telegram group as well as the travel board to look for opportunities to join teams if you are looking to join teams, or if your teams looking, if you're individuals looking to join teams, or if your teams looking for individuals to join your team. All right. I believe we have quite the diverse mix of people here today. So show of hands, where are all my doctors at? Oh, only two. Oh, then you're better going. Oh, come on. Okay. All right. Where are my engineers at? I see. All right, great. Where are my software developers at? Oh, this is very good. Okay, lastly, where are my students at? All right. Yes. Give it up for the students, everybody. Okay, so you can see we are really quite a diverse mix of people. So do take this opportunity today to make sure you network and form your teams. All right. Now, next up for our opening address, I'd like to welcome. For opening address, I'd like to welcome Professor Lynette, Shek, Professor of Pediatric and Head of NUHS Medical Data, here to give us all an opening address. Prof. Lynette, please.
Good morning, one and all, and a special warm welcome to our speakers, our sponsors, invited guests, and colleagues. I apologize for the slightly late start, but this is a Saturday morning, and I think we all start a little later on a Saturday. So this is the second iteration of HealthTech organized by the NUS School of Medicine. And I thought I'd just say a few words about why we're doing this here at the school and what our intentions are. Well, HealthTech is a grassroots, roundabout hackathon organized by NUS Medicine, and is aimed at developing digital health products for healthcare. Now, why do we want to run it this way, right? Why do we want to bring people from diverse backgrounds and different professions and different walks of life together? We believe that the people on the ground in healthcare, so the healthcare workers, do know the problems best, but we are not equipped to solve a lot of the problems that we face. Hence, there's a need to involve all of you, and I'm so glad that there are so many students here today. We want to involve people from different walks of life, diverse backgrounds, and different skill sets to help us solve our problems. To us, there's no restriction on who can contribute to making healthcare better. We believe that healthcare touches all of us. I'm sure we all know someone who's been sick, or we've all had to seek medical care ourselves, and therefore it's important to invest in something like this. HealthTech provides an opportunity for people to come together, to meet people they may not necessarily meet otherwise, and to form well-rounded groups to tackle our healthcare challenges. So today we brought in a great line of speakers, I'm sure you will agree with me, and they will share how they build, how they develop policies, and how they would potentially approach the two issues that we'll be discussing today. That of the silver generation and value-based healthcare. I trust that everyone here today will be inspired to come together and hack together for a healthier tomorrow. So it leaves me to just thank the speakers and the sponsors once again, and of course the Dean of the School of Medicine who sends his apologies that he cannot be here. Enjoy HealthTech 2025. Thank you.
Alright, thank you so much, Dr. Lynette. Okay, so next up we have with us Mr. Lee Hong Yi, Director of Open Government Products at GovTech Singapore. He's here with us today because imagine if we built an organization that operated like a modern tech company but worked on public health problems. Now, he's here to speak on how Open Government Products operates and builds agile digital products to solve public problems. So please, ladies and gentlemen, please give a warm welcome to Mr. Lee.
Hello. Hi everyone. So my name is Chong, and today I'm going to be sharing with you about our team, OGP. Basically, this is who we are. We're a team of about 200 or so engineers, designers, product managers, and we basically do in-house development to build technology for the public good. And these are some of the products that we built. So the team is about 5, coming on 6 years old now, and we built a whole bunch of stuff. There might be some things you recognize. So if you guys got your CDC vouchers, we built RedeemSG at the top right there, which is the system we use to distribute it. During COVID, we built the vaccination system, so that's the health department system. We most recently launched Bright, which is our sort of GP to hospital referral system, as well as quite a few other things that we're working with healthcare on. And yeah, as you said, this is the premise of the team. What if we built an organization that operated like a modern tech company that worked on public sector problems? The idea here is that I think the government and the industry as a whole, there's a lot of things we're doing, and there's a lot of structure in place now to make sure we keep doing those things well. But we do need a mechanism to find new and better ways of doing things. So that's why this team exists. Our goal is to experiment, find new ways of doing things, but not just experiment for fun. We're meant to demonstrate that in our operation, show that it actually delivers work, and finally propagate, to sort of share these practices with other government agencies and try to help transform how we operate our government. Fundamentally, I've said a lot of things, but it boils down to two things. Can we build useful and impactful products cheaper and faster? And I think that's kind of the theme of most tech startups trying to do things, right? Everyone knows there's trade-offs, and you can go slower, you can do worse, and you can do all kinds of fun things, but they aren't very useful. But if you can build useful things cheaper and faster than you can right now, then you win. And that's what we're trying to discover here. So we built things like parking SG. And for that, we've got 134 million parking sessions on the app overall for the last 8 years that we've been live. And our proudest stat is we managed to give money back to people, $47 million in fact. And this was, when you, at the end of the parking session, you take a refund and you get money back. That was a feature we spent quite a bit of time developing and actually lost the government revenue, which is This is the cost for how much these things are. So parking SG costs us, sorry, this is a bit of an outdated number. I'm sure inflation has gone up a bit, but like, it costs about $2,500 a month to run parking SG's infrastructure. That's for the whole country. Not that much. Isomer cost, which is our government website hosting system, so not counting all the build and whatever, but just the hosting costs $840 a month for basically like, I think half of the government's websites. If you move off like sort of internal government stuff, which is pretty expensive, and just use like commercially available solutions. So actually this is a very, very big point that I want to make. A very big reason why you're able to move quickly is not because you have the most specialized tools, but because you have the most mundane everyone can use, and there's documentation everywhere kind of tools. So most of our systems run on AWS, and we use basics of EC2 and RDS instances. You guys know basic databases that all of AWS and all cloud services use, and we get it down 35x reduction in cost. So for this hackathon, you don't need expensive stuff. Like when we're in the midst of our own hackathon now, which I'll share a bit more about later. We're presenting our finale on Monday, and you guys will see it. The budget is actually only $400, and you can get a lot done with very little. Make this concrete. This is like how we built the health appointment system, as you guys kind of see the timeline of this. So this is after COVID, we were trying to take the system and like convert it to a more general purpose appointment system, not just for COVID vaccines. Took about 6 months or so. Started in April. That is who's one of our product managers. He had the idea. He went to run around the team and recruit a bunch of people, like you guys are about to do. And in just 6 months, we got the system launched. In June, in fact, so only just like 2 months later, we got like an initial onboarding for a bunch of clinics. Again, pilot program, just 1 or 2 things, but like an initial run. So that's our useful products, and that's our sort of like my kind of just evidence that we are able to do this quickly and cheaply, and better than you would otherwise, because normally when people think healthcare changes and healthcare products, you take like 10, 20 years to roll something out. So I'm going to share how we do this. I don't think it's anything particularly special. I just think it's like very, very, very focused on staying grounded. I hope this makes sense. The first one is recognizing problems and talking to users, and you'll be surprised how often this step is skipped. So for Care 360 and for Rooster, like the first thing we do before we start building anything is just go really understand the problem as much as possible. So Care 360 is a system for social workers to help keep track of their patients and their notes and everything like that. And the first thing we did was just go and sit with the social workers and see how their workflows are. Really, really just get an understanding and like sort of defeat your own. I mean, if I say social worker, a lot of you guys will probably have like assumptions in your head about like what their workflow is like, what their interactions are like. And some of it will be correct, a whole bunch of it will just be wrong. Same for Rooster, which is our alerting system. We went to the hospital ops center where like these things get channeled through, and it's really like, telephone, like a telephone operating thing. Like all the stuff comes through there, they have to figure out who to route it to and all that. And you need to understand that workflow in a lot of detail. And it's only when you have that knowledge, like that deep understanding of the problem, can you come up with a good solution to it. Because if you have a very shallow understanding of problems, your solutions are equally going to be very, very shallow and not going to be able to solve things that haven't been solved for many years. After we understand the problem, the next step we have is really just diving into workshopping and solutioning. And that's kind of what these health hacks are about. Like the thing that you should understand is that the vast majority of ideas are going to suck. It's not your fault. It's like for my own metrics, which I'll share a bit later. Actually, I'll skip to it now just so you can see. Out of our hackathon every year, these are metrics that I have. Out of 100 ideas at the start, only about 35 make it to the end as projects that people present, something like that. And only about 5 of them become, in the long term, viable products. Now, this is not to dishearten you to say that, like, oh, your product's not okay. This is the point is that you need to go through a lot of ideas before you find something that you think really sticks. And so as you are doing your projects, as you're going, hold ideas loosely. Some ideas will be really good. There'll be a point where you've got a little bit of time left that you really need to lock down and get everything done. But fundamentally, once you understand that that doing good projects, especially in tech, is not about like having the deepest, most committed idea. It's about understanding the space as well as possible, trying a whole bunch of things, finding all the things that don't work, and then converging finally on the solution. So this is the model I have for our team. The medical students might recognize this is slime mold. It's that thing you see on YouTube where they like put it in a maze and it goes around solving the maze. And it seems very intelligent, but it's not really. That's how we work, basically. And the way it seems intelligent without actually knowing very much is just by trying a bunch of things and then resourcing success. So if you watch the videos, the slime mold is not smart. It just spreads its tendrils out in a whole bunch of areas, very, very thin, and then when it finds a source of value, it reinforces it. And that's how we operate. We try a bunch of things, we find a source of value, and then we reinforce, and you get to effectively seem intelligent, which is as close as any of us are going to get. Which is why, I guess they asked me to speak at this thing. We also do our own hackathon every year. So we have a Hack for Public Good. It's the whole month-long hackathon for our team. And we have a whole bunch of projects that we have launched from this. Just to give you a sense, for the last couple of years, we have 20 to 30 something projects every year. And those are the ones highlighted, are the ones that you see came. So Scam Shield came from my hackathon, Redeem SG. Then Postman, if you get your go.gov, if you get your gov.sg SMSs, you'll see that's from our hackathon as well. 2021, we got a whole bunch more. 2022, and 2023. So when I first started doing this, I thought after the first year or two, we'll have run out of ideas and we have done all the things that we, figure out. But you can see year after year after year, we still got dozens and dozens of more ideas. So I want to tell you guys that on the verge of a hackathon to know that there are a lot of ideas. There are a lot of really bad ideas too, and there are a lot of ideas that go nowhere, but there are a lot of ideas and a lot of good ones. So it is worth trying to figure out what you're going to be working on. And in fact, the vast majority of our projects today from our team come from that hackathon. There are a couple of projects that agencies come to us and say, hey, we need your help on this, and we work, but the vast majority come from the hackathon. So you need to understand, exploration, testing things, trying things, these are not just fun things to do on a Saturday morning. These are the fundamental processes that help us innovate and find the best solutions. So yeah, like I said, that is the last point I'll mention is we just resource success. This is the fundamental management philosophy I have for my team, which is I allocate everyone 2/3 of their time to work on what I think they should work on. 1/3 of their time, they figure out what they need to work on themselves. And this means that sometimes they work on the same project because, hopefully I'm doing my job and allocating them to useful projects. But it means that if there are projects that everyone disagrees with, everyone agrees are good, but except me, and everyone disagrees with me that I don't think it's a good project, everyone else does, rather than argue with me about it, they just go do it. And yeah, that's exactly how we resource, and that's how you keep this exploration. You must be willing to hedge against your own idiocy, hedge against your own disagreement, and go get something done. This is the actual resourcing chart for our team. So yeah, I will end this off with my own pitch for my own hackathon project that I am going to be sharing the results with on Monday. I'm doing an education effectiveness survey. So if you guys could help me with this, I know it's a fun way to end the thing. But the idea for this, my hackathon project, is how do we help future students figure out what to learn by asking people who have working experience what they thought was most useful. It's a really, really simple concept, but the idea is that if you want to be a doctor, rather than getting generic advice about what to learn in school, you just ask actual doctors, with 1, 5, 10 years of working experience, what they thought was useful. Same for lawyers, same for engineers, same for all this. So thank you so much for everyone. Thank you so much for the time. And I'll now hand back to the other speakers. Thank you.
All right, thank you so much. Thank you. All right, next up, I'd like to invite Dr. Cheong Wei-Yang, Vice Provost of Strategic Research Partnerships at Singapore Management University and Senior Advisor of Health Economics at the Singapore Ministry of Health. And he's here to give everyone an overview of Singapore's strategies in population health, precision health, and preventative health, and how the development of these approaches in Singapore could be valuable for the region. So ladies and gentlemen, please give a round of applause and welcome Dr. Cheong, please.
Thanks very much. Okay, thanks for being here on a Saturday morning. I know the startup community doesn't really wake up until about 11. So, in fact, when I was at the National Research, I used to work here at the National Research Foundation as the Deputy CEO. And when we first started what you now call Switch, we made sure that the first event started at 11 o'clock. so that people actually woke up and showed up for it. But of course, I've since moved on to a few places. I was actually prior to SMU at the Ministry of Health, serving as at first as Deputy Secretary for Special Projects. For those of you who know the government, it means that you've been called in to do something very urgent. And of course, I actually landed, as I always tell people, on May the 4th, 2020. May the force be with me. Because of COVID, right? And of course, because I was previously at the National Research Foundation, and I was working with all the health and clinical researchers, as well as all the other environmental related work and everything. So I was asked to just go in and use technology to help us to fight COVID. So that was my very simple brief. I landed in the ministry one day after they asked me to join. And then I asked basically, so where are my troops? How do I fight? They said, well, you're the DS, go and figure it out. So I really felt at that time like a Jedi Knight. You land there, you got a lightsaber, so there's an army rushing at you, and then you got troops at you. Okay, so what am I supposed to do? But anyway, 3 years, it was actually quite useful. So Hongi and his team were actually major allies in that work. When we were trying to roll out a vaccination sort of like appointment system, they just said roll up their sleeves and when they talk to people and say what works, what doesn't work, or how do we do this. And of course there were iterations. We vomited blood over some of these things as well, trying to join what was consumer facing systems with the enterprise side systems. Those things actually sometimes take more effort than you really want to know. But in the end it was about just keeping an open mind, talking to people, and of course, trying to join some of these thoughts. I think that was where we actually ended up. So I just reacting to what Hong was talking about, and thinking through, in the end, sometimes you'll find that as hackers, you will try a lot of things. Things that don't work, 100 ideas, 5 products. Sometimes you may get this disillusion, but really I call that building sort of like a GitHub library. Right? What didn't get used today, tomorrow someone else could use. So don't think that everything you do is not useful. Like in research, basically, the fact that you tell people there's nothing here is as important as finding something. Right? So that's the thing to keep in mind. Second thing, of course, is that don't think you're going to change the world on your own. That's not possible. Okay? But you may well create that space where you explore, found success. Then the question is, how do you sound the clarion call, right, to make sure that everyone else rushes in there to actually help you build something there. And that's the kind of role that I sort of like had with Hong, right? He would build something, and then when I saw something that worked, I'll go and tell the whole world that it's going to work, right? So I had some sort of positional authority within the ministry, but there he had the good people, he had that agility, he had that willingness to rethink. The question was, how do you then make sure that these things actually join together and actually create value? Right, so don't think you can do everything, but hackathons like this, where you get introduced to different people, think of all these people as your potential resource. Don't try to solve everything yourself. Figure out where those solutions actually might be, and then ask around. And sometimes, as I always tell people, if it didn't work, maybe today is just not the right day, And then just have a few things on your plate so that you don't feel like you are, go and do something else first, then come back later, at some point in time. And sometimes those things actually work. I talk about this connection between enterprise and consumer grade stuff. So think of those things as well, because in the end, if you're going to work in the healthcare system, people care about the security of their data. People care about large organizations that you have to work with, including the hospitals and so on. So on their side, they need enterprise-grade systems, as they call it. Things that don't just fail, things that, cannot, I just reboot and then I restart. Whereas on the consumer side, they don't mind, because if they reboot and restart and you do it within 1 second or 2 seconds, actually it's perfectly fine, because they don't see any impact. What they want is ease of use, as well as a certain resilience rather than robustness, right? So if the thing fails, hang, you might reboot. As long as you reboot, it works perfectly fine. Okay, but on the enterprise grade side, you reboot while the whole system sits down there and waits for the reboot to happen. You cannot do that. Okay, so understand also what are the various needs and requirements on both sides. Try to build systems that can actually operate on both sides. And of course, if you are not the one who knows how to join the dots, talk to people like InterSystems. Maybe they know how to go about joining some of these things. The third thing I wanted to just talk about is that this whole idea of really resourcing where there is success, I thought I just wanted to shine light on that. So as you look around the room, as you find your teams, understand also who is the one who will give you the right solutions. Where is the crux of the problem? And if the crux of the problem is not where your own expertise is, try and figure out where that expertise might lie. One of the reasons why I came out to SMU is because in SMU we have a very interdisciplinary perspective to things. And so when you look about the interdisciplinary perspective, you need to understand that sometimes it's not your technology, it's that you didn't figure out the business model. It's not the business model, it's because you didn't figure out the regulations. And maybe the regulations, the business model is fine, but maybe the timing and what I call the infrastructure refresh cycles don't fit what you're trying to tell people to do. You may have to wait 3 years, 5 years before you see the product actually really sticking. Because there is a system that's been built, it needs to be depreciated before I build a new system. Okay, so keep all things in mind all the time. And when you think about product, when you think about what you build, think about the business model, think about the deployment, think about the sociology of use, think about you're trying to build something for the aging population. Have you built something that they themselves can easily use? Or even if they can't use it, do they have relatives or well-wishers who can help them to use those products? Okay, so I want to just previous, I know I've used up my 10 minutes of my 20 minutes, but I just wanted to react to that, talk a little bit about that. But now what I'll next talk about is really then maybe what is the operating context within which you should be thinking about whatever health innovations that you're trying to build. Some of you will probably have heard about the 3 Beyonds a little bit more, because we've been talking about that, I think now for easily probably close to a decade. 3 Beyonds basically meant that we were trying to move beyond healthcare to health, because healthcare, we think about it, is really sick care, but really what we want is to maintain health. Second thing, of course, was to move beyond the hospitals, so think about health delivery in the community. Now, of course, you may think, why bother? Because once you go into the community, it means I've got to travel, nurses got to travel. The reality is that often the health system sees cost on the side of their provision, but they do not realize the cost on the side of the patient. And as we have an aging population, right, ambulatory, so people moving around, the elderly moving around becomes an issue. My mother wants to go to see a doctor, I have to take leave. Right? So whereas if the doctor comes, shows up at my home, everything's actually potentially better. Now the question, of course, is how do you then do this in a resource-efficient way? The third thing, of course, is that moving from beyond quality to value, which is that because of the innovations in healthcare, there are a lot of things that can be done. The question is, how much does it cost? And is that the best way of doing it? Are there other ways of doing it? What exactly were you trying to solve? So I think when the Ministry of Health, sometime point earlier under Minister Gan, she came out with this thing, or now DPM, it was really to help the entire system start rethinking what is health delivery going forward, and how exactly should we be thinking about the best and optimal health system. Because in the end, I know often the administrators will talk about cost saving. I like to put it in the other way. It is a language that doctors understand, which is about triage. A doctor has only X amount of time. He has 3 patients in front of him. Which one does he treat? Who does he send to treat which one? Does he do it himself? Does he send a nurse? It's about maximizing your resources so that you actually do the most amount of good. It's not about cost saving. It's about maximizing and optimizing your resources. So whenever you talk to healthcare workers or the healthcare professionals or even the administrators, use the language of triage. Because you tell them you're trying to save costs, they will turn away from you. Because for them, they want to save lives. But triage is about saving lives. It's about the right lives to save, the best effort, and who actually you should be saving and how you should be saving them. Okay, so that's something to keep in mind. Now, of course, as we have the 3 Beyonds, during my time in the ministry, we started thinking very much harder about, if I look forward with the technologies that are coming, how should I be thinking about health delivery going forward? So there are 3 things that we kind of like are trying to build. One is this idea of population health. And of course, population health, now there's Healthier SG, there's H-Well SG, you have heard about some of that thing. What is it really trying to do? It is trying to ensure a certain coverage of service delivery across the entire population. Why do we need that? Because if we talk about big data, if we talk about omics, if we talk about systems that can actually help us to do preventive health, I need to have a baseline of data to begin with. If I have no baseline of data, there's nothing I can talk about. Second thing to realize is that while we look as doctors and so on at health and try our best to ensure that we are treating on the basis of the symptoms, the reality is that each individual is different. Variations from the baseline of the individual is as important, if not sometimes more important, than the actual levels that you're measuring of whatever you're measuring. Okay? Without that baseline of data, you might be a bit lost. Okay, so always keep those things in mind. And of course, with that, the other thing, of course, that the likes of Hong Kong try to help me solve is the integration of care across different settings. I go to the hospital, then I move to a poly, then I move to a GP. Are they talking to each other at the back end? Do I have to repeat my story again all over the time, all over one more time? How well do we integrate care? And of course, after I have care, I have preventive care. How do I integrate care across time? Today I saw someone, today I saw another, tomorrow I see another person, 10 days later I come back to poly as a different doctor. Have we integrated that care over time? Those are the elements around population health that require solutions that you may be able to contribute. Second, of course, precision health, you've heard a lot about it. Most of the time you think of precision health as genomic health, which is looking at the omics, so like the genomics of individual. But for us, omics goes beyond the genomics. It also talks about proteomics and metabolomics, so the stuff that, or metabolic markers and so on that you have in your body. But we also think of electronic health records, because each health episode that you have, for those of you who are scientists, is what I call a state-changing occurrence, phase-changing occurrence. Because today, if I fell down and broke something, there'll be a lot more things associated with that part that I broke compared to anyone else. Something in me has changed in terms of the progression and the directionality of where I go. So there is the stuff that you can't really change, the stuff that is generated by the stuff you can't really change, which is the proteomics, metabolomics, the phase-changing EMR type material, the electronic health record material. And finally, because many of us now wear sort of like trackers and all the kind of stuff that we wear, there's a lot of day-to-day data. If you stare at that data, it's probably very useless. The question you need to figure out is, what is the time scale upon which that data is valuable? And for you to figure that out, you may need to be collecting that data with a high level of frequency before figuring out what is the actual right level of frequency of that data collection, and then seeing how that data helps you to understand the individual as well as the progression of that disease. So that's in the precision health side. And of course, one of the things that I want to emphasize is, why is Singapore so relevant for this? Because if you look at our population, the makeup of Chinese, Malay, Indian, and so on, the reality is that we, because of our genetic makeup, and I draw a triangle of all the mapping of the genetics, we probably cover a good 50-75% of the Asia-Pacific populations. Right? The Chinese-looking people coming from the Oriental side, the basically covers most of Northeast Asia. The Northern Indians cover Central Asia and the rest of that stuff. The Malays actually are what I call the Polynesian tribes that go from South India all the way up to Japan and down to the South Pacific, because these were the seafaring people. So we, in Singapore, have a coverage of genomics that actually allows us, if we do this well and understand the correlations between genomics and disease progression, allows us to serve the entire Asia-Pacific population. Okay? That's why it's valuable, because when you want to pitch something, you want to get someone to invest in you, Singapore at 5 million is not big enough. And of course, companion diagnostics and so on is just something that then goes with it, because if I understand the disease progression because of genetics, then I can have companion diagnostics and so on and therapeutics that are dependent on the stratification of that population. The third one, of course, is that as I do all these things and I begin to understand better the different groups of people, the different disease progressions, who is going to be sicker, who is not going to be so sick even if they got the disease. I mean, in COVID, there were some people I look at them, why on earth did that guy all of a sudden tank? It's not because he's old. I mean, the most older people suffer more. But some people are just perfectly fine, young, and yes, they had problems. A lot of old people were perfectly fine. Stratifying the population allows us to have preventive health strategies, because screening is always good, but you try to screen the entire population, it will always be too costly. Okay, so understanding who to screen, how often to screen, is the only way to make any health technology cost effective. So keep these three things in mind as you think about how you will find a solution. I mean, one last thing I want to say is that because of the affordances of digital health, there is actually what I call digital biomarkers to be recorded, as well as the use of your device as a nudge on the individual's behavior. And all these are going to be very useful tools for you to think about as you develop solutions. So this maybe is a bit more of that elaboration of then where exactly you will find value. So really, population stratified diagnostics, actually sound insurance and payment discounts, because if I do preventive health, it means that I pay today to avoid costs for tomorrow. Who's doing the calculation for you? How are you going to collect your payments? Okay? Of course, then the incentives, and even I would say financial derivatives, because you look at financial products, it's about investing today for payment of outcomes from the future. And so that actually means that, do you have a financial solution to your technological problem or your technological solution? Is something you need to think about. So the rest of it I won't go through because I've kind of covered them. Oh yeah, the last thing will be data architecture, technical standards, and governance. A lot of you who think that you have the product that's going to solve the issues, if you actually can't find a way to address those questions, I don't think you'll get anywhere. Okay? One thing to keep in mind is that I remember talking to someone who was telling me about medtech companies. He came from a very big company. He told me that I don't care about the startups because hospitals need someone to sue. Think about that. Okay? It's not about how good your product is, but when something goes wrong, do you have enough to actually deal with the liabilities? And so if not, no one's going to buy a product. Okay? Keep that in mind. So I just want to end with this slide. All the things that I talked about just now, why is this relevant? Always keep in mind, Singapore is too small. Okay? All that we do, the various things I talk about, population health is about equitable access. Precision health is about quality outcomes. And in the end, preventive health is about sustainability of cost. And we are not just trying to solve Singapore's problem, we are trying to solve the UN SDG goals in our ability to achieve this, not just for Singapore, but for the entire Asia Pacific. Thank you.
All right, thank you, Dr. Cheong, for that. Now, next up, our next speaker is Associate Professor Loh Cheng Wee, Chief Technology Officer of Sheares Healthcare International and Chief Medical Officer at Bridgepoint Health. Now, if you're looking at this topic and you're wondering exactly what the lava lamp effect is, now just like a lava lamp, all right, ever shifting yet mesmerizing in its transformation, this is the change that's happening right now in value-based healthcare. So this segment explores how value-based healthcare is driving innovation, creating a more efficient yet patient-centered system. So ladies and gentlemen, please join me to welcome Mr. Cheng.
You want to go by start? Okay, no need. Yeah, first of all, I want to thank both our earlier speakers because a lot of things you covered, I'm glad it's all elaborating for me. First of all, I just want to take a poll. How many people have seen a lava lamp? Not too bad, a lot. So what is a lava lamp? First of all, it's something that was developed in 1963 by an accountant. Nothing to do with lights. He founded this, he developed this, it became an idea, he launched it in 1963, and then founded a company to make this commercially viable. So now, this is what we see. This is the original, what it looks like originally. But now if you go to Matmos, which is the company he formed, you will find that it has a lot of it, different designs, and a lot of people buy it, okay? So it's one of those innovation that worked since 1963. Then come the point that Zach and the people, the organizers here, want me to talk about value-based care and innovation. And these two are as much as the lava lamp. The lava lamp is an ecosystem, which is the healthcare system. It's made up of very different views of what they're looking for, what people are intending to do. I think Wei-Yang mentioned the three things that he's focusing on, and I think that's how complicated it is. But I'm trying here to share with you my reflections now, coming to about 40 years, 45 years or so, what value-based care is. When I first started, first of all, value-based care was coined by Michael Porter and Elizabeth Holmes in 1906, I think. So it's coming to nearly 20 years in their definition. When it first came out, it was all about quality over cost. And there is a very famous equation where you put value equals value over cost. But for me, value needs one more constant in the equation. And what is that constant? The constant is the patient experience. The patient experience, to him, he's going to see all the things you want to do in value. So if you are looking at value from a ministry, if you're looking at value from a clinician, when I first started as an orthopedic surgeon and when I first heard in 2006 what value-based care was all about, everybody thought, what should you be doing to improve, create value in your organization? So as an orthopedic surgeon, we were told, think about a topic and think about where you can save costs. Make sure you deliver the same quality of care, but at a lower cost. So we started looking at protocols, we started looking at what kind of implants can we use in order to create value. So as a clinician long time ago, value was all about that. As you move on in time, value is not at the system level, for instance, it's about where can you deliver good quality clinical care outcomes to patients at a lower cost, in a lower cost setting. That means if you can treat diabetes, do you want him to be treated in a hospital? Do you want him to be treated by a specialist? Or can he be treated just as well by the primary care doctors? So value when you define value in a bigger context, that's what it's all about. And it's very counterintuitive to specialists. Why should I want my patients to be managed there? It's very counterintuitive. So when you speak to different people, value becomes different things with different people. So for me, I would like to kind of crystallize it to a few points. Earlier, we talked about innovations, what innovation expects. All the things that we talked about. I look at innovation kind of like a framework for the 5 U's. Okay, the first one is, was the innovation designed from a user perspective? Is it a user-centric innovation? And I think Hongi made the point about understanding the workflows, what is happening on the ground, the issues on the ground, whether the innovation went through this process of understanding the issues and of the people who are in the system and the ecosystem. It is, in a way, what we call unlimited, because you want to be able to think out of the box, to see whether you've got solutions that potentially can ease the users and the patients, the people who benefit from the innovation. But the last two U's that I really like, and is I think covered by both the earlier speakers, is the product at the end of the day usable? If it is not usable, then your innovation has kind of failed. Okay, people must find it usable. And usable means don't jump through many hoops just to get to where you want to go. So that's how, if you want to think about how to innovate for value-based care, look at that. And the last one is usability. Usability and usefulness, usefulness is the last one. And for things to be useful for the users, whether it's from the perspective of the care delivery, the service provider, or for the patient themselves, what does it really distill down to? Okay, being useful. In today's context, quality is expected. You cannot do anything that drops down in quality. So quality is always there. The other one, of course, is cost. So whatever you do in terms of creating the value, think of it from the patient side or from the user side. What is it valuable for them? For them, it's time, efficiency. So if you look at your innovation and it helps people do their job better and faster, and it saves time, that's the key. When you distill everything down, value-based care, in whatever context, in whatever design that you want to do, if it saves time for the users, if it makes it makes it more efficient, then basically what you have done is to create value for them. So don't think about the whole process of the original paper, the book that came out on value-based care, which is Michael Porter's Redefining Health. That one came from a very US-centric, a very big system thinking. But for you, if you're going to do any innovation, any design, think about how you create value for the users. And to me, after reflecting all this, it's about saving time and making things more efficient. I think that's about it. Thank you.
Okay, thank you, Prof. Though, can you just hold on to the mic for a second? We'll move on to the Q&A segment. Can I just have you up on stage? Okay, hold on to the mic. We'll get someone to shift chairs around because can I invite back up Mr. Lee Hong Yi as well as Dr. Cheong, all right, for some Q&A from the crowd. So you notice that there are 2 mics stationed on either side. So please don't be shy. Come down the aisle and ask your questions. Just give us a moment as we set up the chairs. Oh, okay. Oh, they're getting the chairs now. Okay, come. In the meantime, all right, prepare your questions. Any questions you have, please walk down the aisle and ask them. Any questions from the crowd? All right, we have one gentleman over there. Oh no, he's just going to the restroom. All right. Now, okay, maybe, oh, you have a question? All right.
Hello, hi everyone, good morning. Thank you for your session and the HealthTech event. I was hearing the first speaker, I think, second speaker. And I am Dr. Bipasha Biswas from UK, Faculty of Pharmaceutical Medicine, London, Royal College of Physicians. You mentioned about population health and precision medicine and preventative health. How would you classify adverse drug reactions in the society? Because I saw in your slide post-marketing surveillance. Now, adverse drug reactions, we are taking drugs every day, which is the 4th largest cause of death. Yet, in the society and in the health sphere, very less importance is given to that, more than oncology or cardiology and all. But having said that, most of the patients in cancer therapeutics die because of adverse drug reactions.
So I think the one thing to keep in mind is that we need to put things in context and rethink the paradigm of how we think about safety. Okay, so that's the point. Maybe I recall a story. During COVID, when we were first trying to roll out COVID vaccines, our Health Science Authority had a lot of concerns because obviously a lot of these things had not been used. What gave them assurance to allow us to roll out was that basically I told them, look, I have the electronic health records, I have basically voluntary submission as well as mandatory submissions across the entire public health system in Singapore. And I give you access to that so that you can actually do post-market surveillance and pick out any adverse signals and immediately highlight it. And if indeed those signals do come up, I will can the thing. Okay. Now, the question is this, right now we spend inordinate amount of times inordinate amount of resources, time and energy for drugs to become regulatory approved. And once it goes on the shelf, people stop asking questions. People stop asking questions because they can't find the answers. But if you look forward, in a world and a society where I have digital health records, where I have access to those records in a auditable way, but somehow safeguarding confidentiality and security considerations, then I may start to think, do I really need to test everything to the nth degree before I register, and then after I take no responsibility for the things that go wrong? I think there's something wrong with that. Instead, what I should do is that I will say, as long as I've proven safety to an enough degree, I should launch. I should then use the big data to justify who this population it really works, which type of population this really works for, which will have adverse reactions, and use that to better stratify and further ensure that safety is actually safeguarded for patients, right? So if I move to that kind of future, then actually much of your concerns, and in fact, a lot of the value that comes from adverse drug reactions would hopefully go away much more than what we're able to do today. And of course, part of precision health, when we call it precision health, we call it precision medicine, right? Because precision health is about using that information to ensure that we don't give drugs for which you have an allergic reaction to, right? This is about pharmacogenetics, right? And a lot of these things is, if I am doing that surveillance, if I'm doing that analysis on the big data that's coming in, I avert a lot more of this kind of issues. But it does require people like Hong giving us solutions in terms of how do I build the data architecture for that? How do I ensure that the data is flowing? And you must always remember this, whenever you collect data, if that data is not incentive compatible to that individual, he's going to give you rubbish. And if he gives you rubbish, you form rubbish conclusions. How do you ensure that people are willing to contribute their data in ways that they don't feel threatened by, but that the system is able to then make sense of to their benefit? That's what we need.
Thank you. I think what you said is, I agree to a certain extent, but in the pharmaceutical world, as a pharmaceutical physician in pharmacovigilance and pharmacoepidemiology and pharmacogenetics, I feel that in Asia specifically, the response rate by the, the physicians or the patients is very low in communicating adverse drug reactions.
Yep.
Secondly, who's going to pay for that compared to the Western countries, where we have the pharmaceutical companies very active in that area, and the government and the regulators, which I do not see in this region, but Singapore is, I do not consider Singapore in that region, beyond Singapore.
Yeah.
So how can we especially work on that to encourage young budding physicians to make it a point to report adverse drug reactions, and the patients also to do that more consistently?
Yeah. So again, I take a philosophical perspective, I take a step back. When you don't even get access to drugs, you don't worry about the pharmacogenetics as much. Okay? Access is itself part of the problem we're trying to solve. Right? And if you don't have access, you don't worry about whether I take the drug, I end up having this. Of course, where you have access, where the government pays for access, you start worrying about pharmacogenetics. So that's the first thing to keep in mind. I'm not trying to belittle the problem. I'm just trying to say that you must understand the context upon which we operate. Now, but I have a lot more optimism because I see in Asia and the Asia-Pacific region the rise of digital tribes, as I call them. Okay? A lot more of us are digitally connected. I don't need a doctor to report. My reporting of my symptoms is itself democratizing some of these surveillance possibilities. But we then need to make sure that in that reporting, there's a way to filter, there's a way to contextualize, there's a way to sort of ensure that it is not overblown and so on. But I believe that with the technologies that we have today around the digital ability to sort of submit information, as well as some screening through LLMs and so on to actually help to translate, there is that kind of future that we should be aiming for. I leapfrog the systems that the West have built to have systems that actually much more achieve the objectives that we were trying to do, while not being caught in a situation in the West where, because of all these concerns, there are drugs left on the shelf that the pharma companies don't want to bring in, because to try to answer all those considerations and concerns means that I have to spend too much money, and a lot of patients are not getting what could work for them. And of course, what we need to determine is which groups of patients does this drug really work for. And hence the system I talked about is the way to get there, to make sure that drugs don't get left on the shelf, that people who develop drugs have a way of getting paid for it, right? But meanwhile, they are also responsible for it in terms of ensuring that only the patients who are stratified to use it with the right companion diagnostics actually will use it.
Thank you. You said about access to medicines, but...
Sorry, I think we need to... can we give opportunity for others to ask the question?
Yeah, I'll ask later.
Yeah, just to answer, to add on the points being made, why don't you ask your question? We'll talk about it later.
Okay, next question, please.
Yes, hi. Thanks for your talks. I think, Dr. Chong, you said, the Singapore market is too small to build anything here. Yet we have Mr. Lee building things very specifically for Singapore. So which advice should we listen to?
We don't make any money from this, I'll just tell you straight up. I'll let Dr. Chong sort of share a bit more from the buyer's perspective, but from the sort of creator's perspective. Fundamentally, the reason why I'm doing this is precisely because, as you said, it's a small market and no one's going to solve the problem. just to give you a bit of background, I was an econ major. I studied like free markets and all these kind of things. A big sort of Chicago school guy. But there is something to be said of just like needing someone to do it. And there is, no matter how much you think there is a market for all these various things, there's always going to be a residual of problems that need to be solved, but just due to whatever happens, circumstance, or the structure of the world, the market does not solve. So I can tell you that, like, yeah, for most of the things we're working on, like, you could say, oh, just put out a bid, put out a contract, and market do its thing. And again, when I was an econ student, I used to say the same thing. As someone who's practically trying to get these things done, it is a lot faster to just have capability to go move and get these things built. So for most of our if you look at all these little individual systems and components, a lot of the time the failure comes from understanding these like individual components and as Wei-Yang was sharing, like really knowing the details of the problem before you go in there. And so it is extremely hard in our small market for there to be enough a large commonality of these like minutiae to build something. Maybe the Americans do, and we've tried to buy some of their systems, but it doesn't really apply to us in a lot of cases. And when we try to import it wholesale, it just doesn't quite fit the whole. So yeah, there are a lot of problems, and I don't know, maybe someone more business-minded than me will be able to look at our dozens of products and figure out what we can take to commercial solutions. My view is that commercializing a good product is itself, even if you have the good product already, commercializing it is a lot of work, and it is a really, really non-trivial problem, even once you know the product's good. There's all the salespeople, all the marketing people, all the operations, all that. And so we just like, I find it's just not worthwhile. Maybe you will.
And just I'm not asking you not to work in the Singapore ecosystem, right? The reality is that the Singapore ecosystem's advantage is that we are well connected. I talked about integration across time, across settings. That's what we're trying to achieve. We are building what we feel is a system that allows you to demonstrate real value of your product in ways that no other system can, in ways that no other system can give you that kind of data integrity, assurance, and so on, right? So, but the point is that don't try to earn money off us. If your ambition is to try to get contracts from the 3 healthcare clusters in Singapore and think that with that you go and retire and buy your own bungalow, I would say, I'm sorry, I probably can't work with that well with you. But if you want to solve the Asia Pacific's health problems, I mean, just give an example. And we are trying to roll out digital systems into the community that the elderly can use. But if you think about it, if I'm successful with that, it means my elderly don't have to travel. But more importantly, you have the infrastructure and the backbone for a healthcare delivery system into every rural village across the Asia Pacific region. This is what I tell the tech executives. That's why they come to work with us, right? Because you work with us to develop solutions that, of course, are useful from Singapore's perspective, but in that process, earn your money from the 5 billion people in the Asia Pacific region. That's what you're here for, okay? And of course, in that process, I ask you, sell me a product at cost plus, right? I cannot make you make a loss, but see us as co-development sort of like partners, see us as people who will help you to refine your product, see us as people who will help you brand your product, because Singapore uses it. Okay, and that's why you're here.
Okay, we have one question over here.
Thanks for the wonderful talks and the discussions. My name is Nidhi. I'm the chairperson of the Alliance of Patients Organization Singapore. I also head another charity that's been around for 13 years. Unfortunately, the situation is nobody asks patients what we want. So that's the voice I want to bring in here. When we talk about value, we need to find the value that the patient rates the highest. Yes, I agree on the part about saving time, saving cost, efficiency. I come from management and finance background. I have a couple of masters. But I also have a few illnesses that I was diagnosed with. I have recovered using various wearables and other systems. I am a compliant patient, but today I'm here because I'm very interested in this hackathon, because patient voice needs to be included. So in this tiny Singapore, we have 100 patient organizations registered under the Ministry of Health. Reach out through us and let's co-create. That's all I want to say. Thank you.
Thank you. All right, thank you so much. We have one more question.
Hi everyone. everyone. My name is Faye. I'm a junior doctor in the Singapore public healthcare system. I think I just wanted to ask the speakers, I think from a healthcare perspective, there's like a lot of players. There's like your patients who want care as fast as possible, as cheap as possible. There's our physicians who are very overwhelmed, you know. You have a long line of angry patients waiting at the door, you're overrunning your clinic times. Then you have the healthcare administrators who want to reduce costs as much as possible, and you want the largest volume flowing through the hospital system at any one point in time. So when like interacting with users on the ground and collating feedback, information, how do you account for all of these competing demands and needs, and how do you prioritize? Thank you.
As a hackathon person, the general advice I would give is don't start with global optimization, start with local optimization. So the analogy I give, it's a bit like a Rube Goldberg machine. You know what a Rube Goldberg machine is? Have you watched those videos where like someone rolls a marble and knocks over a broom and it turns on a TV and it scares the cat and it does something like? So a Rube Goldberg machine is very interesting because it can be arbitrarily complicated and arbitrarily long, while every part individually being critical. If you took out any part of that long chain of events, the whole thing would fail. So you cannot optimize those things by looking at the individual components. You have to optimize those things by looking at the larger system and then bypassing individual components. Because if you just talk about removing individual parts, you'll fail. So that is very, very, very hard. In general, when we try to do these things, you build your way up to global optimizations. So when our team goes and explores different things, we don't look for like, oh, how should the world work? Oh, actually the fundamental problem is the financing structure for physiotherapists or whatever the hell it is, problem we're trying to solve. We say that physiotherapists have to scribble a lot of stuff on paper to give to their patients. Let's just not have them do that anymore. Let's have them just tick a checkbox and then the patients get an email, and that's clearly better for everybody. So you work your way up to the point where you don't find any more of those things, and then you start looking at the more global optimizations. So, for example, one of our products, DigiMC. Instead of getting the little paper chip from the doctor, we send you a link, and it goes on mc.gov.sg, and it's your digital MC. This is better. Now, is it the fundamental thing that is going to transform our healthcare industry? No. But it is a small win that we know that we have. And the way me and my team think about it is that you just go around trying to find as many small wins as possible, and then that lets you understand the space. And when you understand, and once you've got enough of these small wins, you can then look at the larger system and then try to do a more general optimization of like, we've done all these things, but actually we keep hitting this bigger block that's like hidden deep within the system that you need to understand, and then you try to get there. So it's non-trivial, but like I think but it is, you know, I at least working in government, I found this common pattern of, you know, extrapolation to failure. That people will sit around and they'll start solving a problem and they'll use their big brain and they'll start thinking, oh, but if we do this, then this will be a problem. If we do this, then this will be a problem. Do this. And therefore I conclude that the problem is too big and therefore I should just sit here on the sofa. Which happens. And you're not wrong. Sometimes it is true, it is complicated, but like you start chipping at it and you start getting, and then you start building understanding, you get a depth of it, and with years of doing this, maybe you see some insight that no one else has seen yet, and then you can make a play. But it is very, very easy to conclude. And I've seen this for a lot of projects where I'll go present to a ministry and they'll be like, if this, if this, if this, if this, and this, but this will block anyway, so let's not even start. And I don't do that. Yeah.
So I think Hong is correct. But I think both of us see the world from slightly different perspectives. That's why we work very well together as well. I'm thankful for a lot of things. In the end, if you don't have people at home trying to solve the local problems, nothing gets done. But I think there's this very sort of like popular term used in the public service, which is this helicopter perspective, which means that I can go all the way up, look at things, and then I can come back down to the ground. And basically, so helicopter is not you hovering there and do nothing. You go at the top and see what's going on, and you go to the ground and get things done, and come back out again and see what else needs to be done. The system perspective is very important. But understanding where the crux of the issue is, where the success, and then once you decided that that's the place where a problem needs to be solved, how does it actually get solved at the local place? Why does a doctor use any of this stuff? It's not because he wants to save costs for you. It's because so he can go home at 6 o'clock and pick up his daughter from school, and then actually still have a dinner with his wife, right? Or her husband. Those are the reasons locally that's why change happens. But if you just use that as a basis for change, you don't solve the global problem either. So the question is to understand what is the global problem. Take a step back and say, fundamentally, if I'm trying to address some of these things, what needs to change? Now, those changes don't happen overnight. Have patience. But what you need to do right away is then figure out which are the pieces that can be done immediately, low-hanging fruits that can actually start. Get the right people, the right teams to go and work on those things, and realize that when all those things fall into place, the global system change will happen. But you need to think both directions in order for you to be successful, which is why I keep trying to tell people, don't think you can solve the entire world's problem. Even the guy who's looking at the big picture, like myself and so on, can't. I need people like you to find the solutions on the ground. But I will tell you why it's valuable, whether it's valuable, or whether you should do it now or do it 3 years later, because the system is not yet ready to take some of these things in. But if you really want to do it, I'm not going to stop you, because I just keep you in the libraries until such point in time when I can activate you for the system level sort of use. Okay, so that's the way I'll answer the question.
I totally agree with all the comments, especially the point I'm trying to make is that that's why I made that comment earlier, that you need to distill all the things down to who the person you're dealing with in front of you. What are the problems you're trying to solve? If you start working on that, it's incremental. Because we are in a big group of hackathon, we are looking at different aspects. Some of you may come from institutions, some may come from tech companies, some may come from pharmacy companies. All these are small areas in which if you help each of them solve their pain points, their inefficiencies, their bad patient experience, whatever they are facing, you will over time incrementally improve the healthcare system. If everybody is saving costs at small points, the total healthcare cost will come down eventually. But if you jump from on top and say, I want to do a reduction in healthcare costs for whatever it is, it's not going to work, because it's just not the way it's done. You cannot just improve efficiency when you look at so many levels of interconnectivity and how each affects each other. You just can't start with a global product or solution that solves everything.
Okay, we have time for one last question, so I do apologize for those that are in the queue. Of course, later on during the tea break, you'll have an opportunity to catch our speakers. So we have time for one last question. Okay, this gentleman over here. Last question goes to you.
Hi, thanks for giving me this honor. I come from one of the 3 healthcare clusters. I do enjoy using OGP's products, notably PAIR. In our workplace, there are other parties involved in the health tech innovation space. So wondering, how does OGP see your role in the public healthcare clusters, and how can we perhaps engage OGP through whatever channels? Thank you.
Yeah. The fundamental premise of our team is that we do whatever needs doing. I think that is how we start, and I think that's where we deliver value. And not to say that the opposite premise of just like starting from a strategic perspective and going in isn't useful, but I think the way we see, the reason why I founded this team was because most of the government works in a very top-down, pre-planned manner, which is a good thing. The government does plan things and they roughly structure things and they go. But when you are top-down and going, you often miss nuance and cracks and opportunities that you don't understand. The value that we saw was that if you have someone on the ground who really understands the space and the technology and all the things, you will see opportunities that are maybe not the sexiest, coolest idea, but are problems that should be solved. And you can go in there. So I'll give you an example. So for Parking SG, if you were to ask like 10 years ago, what are strategic national objectives for our digitization? No one's going to say, oh, parking coupon. They'll say, you know, AI or cloud or whatever the hell, you know, you're doing nowadays. But often when you go on the ground, you realize that it's these little tripping blocks that really make your life suck. So for Parking SG, it's not that, you know, if you're rich enough to have a car and then you have to fumble with the coupon, it's just annoying lah. It's not the worst thing in the world, but it's freaking annoying. So you solve that, and it does make your day worse. Same for the hospitals, right? For our system Rooster, it is not like a strategic problem where we do not have a centralized healthcare database and AI-driven blah blah blah, but it is a tripping block. It is a small but really annoying tripping block that, like, when the test results come in, they have to like look up this and like call a whole bunch of doctors and try to figure out who to get and get the information to, and it's stupid. And so we fixed that. And it's not the sexiest problem. It is not the kind of problem where you are going to make a big, you know, sort of grand statement around, but it is a real problem that real people face and can cause a lot of real damage, very importantly. And that's kind of where we come in. So when we work with the clusters, it's really with that mindset. So for this hackathon itself, we have a bunch of people, we have a bunch of sort of friends in healthcare, and we just go talk to a bunch of them, and we come up with problems. And then we try a bunch of things. Some of them work, some of them don't. Some of them don't work this time, but might work like next year or the year after, as what Wei-Yang said. It's maybe just not the right opportunity or the right time or whatever, who knows. The general philosophy I take is I'm not terribly strategic about these things. I'm not like, oh yes, I have to go this product. I'm just like, what is the simplest, cleanest wins I can get? And if I keep taking free wins, eventually you're in a better position. So yeah, if you have ideas for like very specific, like if you, the more clearly scope the problem, and the more easy it is for you to get a clean solution on the ground. Yeah.
And maybe I will just speak a bit more about that as well. I am a, okay, without trying to contradict Hong, I'm a systems level kind of person. And the reality is that much of what Hong was able to do was also because I got the Synapse side of the house to cooperate and collaborate, right? Care 360, which was one of the biggest successes that they had, was because I took the team inside this and sat them down and said, look, this thing is not working. How do you make sure that something like that can work, but interface with the enterprise-grade system so that both sides actually can use this system well, right? In the end, I think what Hong says is correct. You can't just sit down there and say, this architecture, blah, 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 and then expect things to happen on the ground, right? So I find that what Hong and his team does activates and facilitates the solutioning. But yet at the same time, there must be someone looking at things from a larger system perspective and thinking, how does things actually integrate eventually? Each of the tools that they have built is actually part of a larger system that I think we will be using as part of our health system going forward, right? Care 360, I'm going to push care into the community. Am I going to open up my, Epic system to all these people out there? What's the security considerations? How much do I have? How many loopholes? How many hackers and so on can actually come through that? I'm not going to open it up. But if I have Care 360, Care 360 is used on the ground. Care 360 integrates with the EMRs, and I have a secure gate. This is one of the things in the library that will become very, very useful in the future, right? Keeping those things in mind is how we drive change for the entire system. But you cannot just sit down there and say, oh, I want this, and then, because they were solving a real problem on the ground, we were able to deploy, implement, and demonstrate that it works and people can use it. Without that demonstration, nothing is going to happen, right? So I think in the end, it's a combination of the two. OGP products, if you think about it, are very oriented towards the user, right? And the user is how should I say, you give it an enterprise-grade system. The enterprise-grade system is safeguarding the institution and the organization, not as much thinking about the user. And it has to be because there are larger considerations. But the question is, as we go forward, as we have AI systems, as we have, do not think in only computing data architectural systems. We have a system going forward that is going to be both data-driven as well as with humans operating in it. If I cannot interface directly EMR, I can use you, because you have the password into EMR, to take from their system and go into there. You are part of that system. So think of the entirety of the data and the human systems, like the automated and the thinking, sort of like a professional, to build that system that allows you to have the kind of change that you're looking for.
I have one controversial point to make. I hope I don't lose my connections and friendship with the clusters or Synapse or whatever it is. But the question is from an article in forum. They asked a very poignant question, and I don't know who is going to answer that. It's why so many apps, health apps. How many appointment system apps are there? There's, it's available in Health Hub, it's available in HealthTech. It's all different aspects of what they want to look at. But there's so many apps. So the public is inundated. So one of the things that we talk about system level is we should think about what's happening in the ecosystem now that potentially may be creating its own inefficiency for the patient. So that's the point I was just trying to make.
So maybe I'll quickly answer that because don't worry, and this is a question actually within the ministry we ask all the time. In the end, it goes back to Hong's point. How do I drive implementation? If I have one app that's built by Synapse, none of the clusters are going to use it. If the cluster builds their own app, the cluster will use it. Okay, that's the first point to realize. But it's the patient that we care about. So what we did was that while now there are still 3 different apps from the 3 different clusters, the back end is a common system. But each cluster app will have their own innovations. But the way I've actually run this is to say that anyone who comes out with innovation, who can persuade another cluster out of the other 2 to use it, centrally we will fund it. Remember, so I do take a point. It's the thing that we ask. In fact, Minister asks it all the time as well. But the question is, in the end, think of both sides. So both the cluster side, what are the incentives for people to want to innovate? They want recognition. If you don't recognize them, then they may not innovate. But then after they innovate, can I then make it central and everyone can use? Was what I tried to create. Now, of course, I then slowly, slow boy, build the back end, make everyone have to, and anything you want to do on your own, you pay. Anything that other people are willing to use, I will then take the cost back and make sure everyone can get to use it, because then I'm taking your IP and giving it to other people. That's how we are solving that problem a little bit.
Okay, I do need to end off the Q&A here. Thank you so much to all of our speakers. Please, round of applause to all three speakers. Thank you so much for this Q&A. All right, just give us a moment as we move the chairs away. Thank you so much. All right, next up, we have Dr. Wang Zhemin, consultant for internal medicine and intensive care medicine at Alexandra Hospital, as well as the tech and medical informatics lead at NUHS at home. He'll be touching on what if hospital care could happen at home. Now, this talk will explore how decentralized care models and technology can redefine patient care. So can we please have a round of applause to welcome Dr. Wang, please?
On the first slide. Okay. Hi, good morning, everyone. Thank you for the invitation to share today, and thank you for the esteemed speakers preceding my talk today, who have done a fantastic job in setting the stage and laying the foundations so that we can talk about healthcare innovation in very specific contexts. So today, I'll be sharing about NUHS at Home, which is the NUHS Hospital at Home program. We'll be sharing about our experiences and some of the challenges that we face today, and perhaps that could provide food for thought for your hackathon. So for the first slide, I'll be playing a short video to provide a background context of what is Hospital at Home or MIC at Home in our local context.
MIC at Home or Mobile Inpatient Care at Home is an alternative inpatient care delivery model that offers clinically stable patients the option of being hospitalized in the comfort of their own homes. These patients will be cared for by a team of healthcare professionals who conduct regular teleconsultations and home visits. The level of clinical care patients will receive under this care model would be similar to that in a hospital.
When a patient's condition is deemed stable, after completing the necessary diagnostic tests, or when requested by the caregiver or patient, their primary clinician will assess their eligibility for MIC at home. If suitable, the clinician will confirm their treatment plans before the patient is sent home.
As patients are advised to remain at home, their treatment plans will be adapted to suit their living habits and home environment. This patient-centered approach ensures a more comfortable recovery and even promotes a smoother transition back to their pre-hospitalization lifestyle.
When I was admitted to MIC at home, I was a little worried at first. What's it like to be hospitalized but at home? How will the doctors and nurses take care of me and ensure I recover as compared to if I was in the hospital? But soon I could see that the care team was very well trained. The care team communicated clearly with me and explained to me things that I did not understand. This boosted my confidence and trust in them, and I knew I was in safe hands while recovering at home.
Apart from receiving medication and the necessary equipment right at our doorstep, I was pleasantly surprised that my daughter, Sophia, could receive IV drips at home, and she did not have to go to the hospital for blood tests. It was really convenient because I didn't need to make major work adjustments to bring Sophia to the hospital.
Recovering at home is less boring, as it gave me the freedom to do light tasks around the house. I could even work from home when I was feeling better and enjoy home-cooked food. I like to be around my family, and this also made it easier for them as they did not need to travel to the hospital to visit me.
Having 24/7 access to the care team eases my mind, because I know that I could get help from my mom.
Okay, so maybe in the interest of time, you can go back and view the rest of the video, but I hope that provides a bit of an understanding of what MIC at home, or what we term mobile inpatient care at home in Singapore, entails. Okay, maybe you need help with the next slide because the clicker is... Okay, so why MIC at home or hospital at home? So I think we can think about it from two main perspectives. So firstly, from the patient, as our previous speakers spoke a lot about focusing on the patient experience and what it means to receive medical care. Hospital at home actually allows patients to recover in the comfort of their homes. There's familiarity and company of their loved ones, and there's also reduced risk for problems like hospital-acquired infections, or even in elderly patients where an unfamiliar environment can predispose to them getting problems such as confusion and delirium. From the system standpoint, we are faced with an aging population, and over time, in finite land-scarce Singapore, we can only build so many hospitals with that limited number of hospital beds. So hospital at home actually provides a long-term, tenable, scalable option to meet our healthcare demands. And potentially, if at scale, this could be also delivered at a lower cost. So, as I understand, the theme for today's hackathon is about value-based healthcare. So while the equation that is commonly talked about is about quality over cost, I think the focus is really looking at what constitutes quality, both from the patient aspect, where we look at patient experience, patient-reported outcomes, from the medical aspect, what is considered appropriate care, and of course, important things like quality and safety that have been raised today as well. So just a quick sharing about the NUHS at Home program. So this is a program that provides care for patients who would traditionally be hospitalized in a physical hospital. It's been established since 2023, and we receive patients from the community, from A&E, and from patients who are currently warded in the different hospitals in the NUHS system. And the goal essentially is so that any patient who wants to be cared for at home can do so in the comfort of their homes. And we look after predominantly patients in the western cluster of Singapore, and our operations essentially entail different aspects like daily visits, that is physical visits to the home as well as tele-visits to with patients. We work with vendor nurses and vendor providers to deliver care. We use remote vital signs monitoring, and we also have complex logistics to deliver medications and equipment. And all this work behind the scenes, we have care coordinators working very hard to ensure that care is delivered in an appropriate and timely fashion. So as you can imagine, what we're doing here with MIC at Home is essentially decentralizing care. When we look after patients in the hospital, everything is under one roof. Things are centralized, and with centralization, it's easy to coordinate your different moving parts and different efforts. And actually, if you think about hospital at home, this really isn't a new care model. If we look back pre-19th century, actually most of hospital care or medical care was actually delivered in the home settings. And as we industrialized, as we looked towards modern medication, hospitals became a thing of the 19th and 20th century. But currently, as we re-examine the way care is delivered, as we re-examine what it means to deliver good care to the patients, we are now actually seeing value, and perhaps with emerging technologies, emerging digitalization, some of these can be done in a more efficient way. So if we look at challenges, we can break it down into a few key aspects: the clinical, the patient, operational, technology, and financial. The points in bold kind of are some of the areas of focus that we may want to consider about. So from the clinical aspect, we need to choose patients appropriately. We need to look at how we do remote vital signs monitoring, which I'll delve in a bit later. And communications as well. How do we do so in a remote setting? In the hospital, you can call your nurse with a call bell at any time point, but how do we do so similarly in a home setting? And how do we escalate care and have expedient systems when patients deteriorate? From the patient point of view, how do we ensure that we do not burden caregivers additionally when their loved ones are sick? How do we ensure that patients can be cared for appropriately in the home environment? From the operational front, as you can imagine, as we scale, the logistical and considerations are very extensive. And how do we do so to ensure that medications don't get missed, patients get their vendors attending to them in a timely manner? And from the technology front, there are many challenges. How do we integrate technology, ensure that there's appropriate security and privacy? And from a financial standpoint, how do subsidies, insurance, and incentives align appropriately? So I'll be focusing on a few key areas so that this could provide some food for thought. So remote patient monitoring. So instead of now, in the hospital, your nurse can attend to you anytime. One of the sort of safety nets that we built into our program is to have remote patient monitoring. And the ideal patient monitoring system will be one that is accurate, one that is comfortable for patients, so it doesn't get in your way, it doesn't squeeze your arm too tightly, or it's not too uncomfortable when the patch is on you. It's effortless, so we have some elderly patients who may even find something as simple as keying in their vitals into an app challenging. It has to have stable connectivity, tailored to accuracy. So, while people espouse the benefits of continuous vital signs monitoring, the truth is maybe not all patients require it. Ideally, we want it to be cost effective. We want there to be alerts and deterioration prediction systems so that this can enhance safety. And we also want things to be integrated into our EMR. Looking from things on the patient experience, we want patients to be able to have a seamless digital experience. Our present state is far from ideal. We have complicated WhatsApp groups with multiple providers inside. It can be a bit confusing for patients and even challenging for providers because, when patients ask a question, we don't know who it's directed to and who should respond to it. The vital signs monitoring platform is a separate platform, so that means that patients have to interface with multiple digital tools. And at present state, we face challenges with EMR integration as well. So what could potential solutions look like? We are exploring existing CRM solutions like PepperCloud, Speedback. We are looking at some native solutions to our EMR systems, such as this tool called MyChart Bedside. We are also exploring collaborations with our local NUHS app as well as the cluster, or rather National App Consolidation Task Force that was alluded to earlier by Dr. Cheong. And at the telehealth work group at the ministry level, we are also exploring how device integration can take place. So as you can see, there are many stakeholders, many moving parts in this bid to really improve a seamless digital experience for patients. And what do we hope to be entailed in it? We want communications, we want information to be provided in a seamless manner, we want patients to be able to interface with these systems easily. We want there to be medication oversight, treatment plan oversight, and we want even things like last mile, geolocation tracking, so that when, let's say a vendor is coming to your place, you would know that the patient is going to arrive in 5 minutes, 10 minutes, so that you can plan your day as well. From the operational front, it's really challenging at present state. And as we scale, as you can imagine, we have patients located in different places. We are trying to coordinate home visits, medication delivery, nursing visits. And the present process is very labor intensive. Once again, we interface with multiple systems. We use things like Google Cloud, Google Docs. We interface with different systems that different vendors use. And information flows are faced with delays. Information drops here and there can be suboptimal last mile delivery. So what would a future state look like? We hope to be able to consolidate all these operational demands into a single platform, and hopefully this can facilitate booking and tracking of these services as we partner with our vendors, and ultimately also hopefully leverage on AI and automated tools that can facilitate some of these scheduling functions. And for this slide, we look at how we can leverage technology in different areas to enhance efficiency. One of the areas that I'll be just quickly sharing about is how we can use perhaps artificial intelligence to predict patients who would be suitable for our program. The current process of bringing patients in is quite manual. We depend on providers to make referrals to us. So how can we proactively instead of reactively bring patients in? So we're also exploring technologies in this front. So in summary, what MIC at home actually represents is a care model that acutely unwell patients can be treated at home in the comfort of their home environment. However, the decentralized care delivery model actually, as well as the home environment, represents unique challenges, and we would have to rethink the way we deliver care instead of wholesale replicating what we do in physical hospitals at present state. The clinical, operational, and technological innovations are crucial and important in facilitating our scaling and growth over time. And for NUHS at home, we hope to be able to scale to 400 beds by FY30 from our present state of 60 beds. So if there are any solutions or any innovations that can help us to improve our efficiency, help us to improve our patient safety, and help us to improve the way we deliver our care, we would very much be happy to collaborate. Thank you very much.
All right, thank you so much. Thank you. Thank you so much, Dr. Wang. Can you please stay on stage for a while? We're going to have a Q&A with you. Let me grab your mic. There you go. Okay, any questions for Dr. Wang? Yes, please. You can go up to the mic right next to you.
Yeah, we all know patients, they don't like to go to hospital, right? So we want to provide them care at home. However, like the more patient they aged, they get into more complication, more disease, right? And you need to collaborate with multiple providers, maybe cardiology, neurology, many. So I'm just curious, like, is it a viable solution, home care? Because now this collaboration, is it going to cost a lot? Because we have nursing home, we have home care, I'm thinking like economically, right? Like, and for a patient who are ultra rich, of course, they can have people visit at home. Especially if you go to country like US where public institutions are less, more private institutions are there. So there is a place to exploit, right? So anyway, my point or my question is, by looking into all these challenges, right, what is your view about this model, in future? Like how long it will take to streamline and become economically viable for patient?
Thank you for the question. So I think there are a few components to this. So I think firstly, especially when we started off, we tended, as you rightly mentioned, to choose maybe simpler cases. And I think like what Hong-Yi also mentioned earlier is maybe starting small, starting with patients whom we can see, patients who could easily be managed, perhaps less complex patients, which could be managed in a safe manner at the outset. And over time, actually, what we have seen is that we started to actually manage more complicated patients as well, more complex patients. And this is where we look at leveraging technology. How do we do things like tele-collaboration, right? Just because multiple specialties are required to care for our patients, it doesn't necessarily mean that the cardiologist, the respiratory physician, the nephrologist all need to descend to the patient's home physically, right? So right now, as we speak, actually, this is one of the challenges that we face. We are looking at patients who require multiple consults. How do we organize that? How do we organize care around the patient? And how do we leverage technology in order to do that? So I think the few pieces would be, how do we choose patients efficiently and effectively? Secondly, how do we gradually, incrementally increase our capabilities and our capacity to deal with more complex patients? And how do we imbue technology in order to address these issues? And of course, I guess as we expand and all that, how we are even looking at having maybe specialists within our team instead of just depending on purely consult based. So I think it's definitely work in progress, and these challenges are absolutely real. But yes, I mean, happy to see whether or not there are any solutions that can be garnered from this event as well. Thank you.
Thank you.
All right. Can we have a next question? Please.
Hi, thank you for the sharing. I'm a master's student in behavior implementation science with BC. So my question will be more towards the acceptability of patients. Yeah. So having more tech and doing tracking, do they have like privacy concerns? How much do the caregivers and the patient accept this? And also the fidelity question. So how about accuracy of the diagnosis using the tracker, and as well as the fidelity of the care by the caregivers when they're at home?
Yeah. So thanks for the question, and indeed these are things that we grapple with as we choose our tech. And we've gone through different iterations, right? So and in fact, the way we deploy tech actually is kind of patient stratified or need stratified, right? So actually for some of the maybe more stable, simpler patients, we actually do just point of care monitoring, meaning that it's quite low tech. They actually check their blood pressure themselves, and then they just key into the system. So in a sense, for these patients, there really isn't very much continuous monitoring or tracking per se. Of course, we need to ensure data privacy when we work with the different systems, etc. Then maybe when it comes to patients who maybe are on continuous monitoring, as over time we start being able to track more things, like even, let's say, geolocation tracking. If, let's say, patients, right now we try to keep patients at home, but if, let's say, over time we say that maybe they can go out, and then there's tracking of these movements. Yes, these indeed are things that we have to consider. But at the same time, I feel it's oftentimes a discussion with patient, going back once again to the patient, right? What is important to the patient at that time point? So of course, in the ideal world, we want our privacy, we want our care at home, we want all these things. But in a patient who's faced with an acute illness, and yes, certain patients may feel that this is not care that they want. They may be concerned about privacy issues, they may be concerned about, is this safe? So I would say that, number one, there are some patients who hate hospitals, so these patients are the easiest to bring in. There are some who love the hospital, so these patients, we don't have a chance. But there are those in the middle where a lot of it is perhaps over time we learn to convince them. We find out what their concerns are, and we work with patients to allay some of these fears as well. In terms of fidelity of care, then once again, this is where we look at how do we build protocols, how do we build in safety nets. Of course, care in the physical home versus care in the hospital will never be 100% the same, but safety is a very key consideration, and we build in appropriate escalation protocols. And over time also, how do we leverage on maybe vital signs? Can we pick up deterioration earlier? Can we bring patients into hospital earlier if they require so? So these are things that we're also looking forward and working on in the long-term horizon. Hope that answers the question.
All right, thank you so much, Dr. Wang. That will be the end of the Q&A. Please, round of applause for Dr. Wang, everybody. All right, next up, we'll be moving on to our panel session. So first up, let me invite our moderator on stage. He's none other than Mr. Aristotle Ang, General Manager of NUHS Medicine Digital Advanced Technology Accelerator. Welcome. Here you go. Can we please bring up the chairs for the panelists? Thank you so much.
Hi, good morning, everyone. Nice to see so many bright faces here today. So since all of you know that our hackathon has two challenge themes, one being value-based healthcare and the other being the silver generation, I'd like to kickstart the portion on silver generation with a panel session. Today we have two panelists joining us up for a session entitled Empowering Aging, Innovations for Independence, Health and Connectivity in Later Life. Our first panelist is Professor James Carr. He's the Associate Professor in the Department of Biomedical Engineering, and he's also the Vice Dean overseeing outreach and special projects. He teaches gerontology and has deep experience co-designing solutions in the elderly and disability community space. Welcome up, Professor James. And next, joining us with a lot of experience, Miss Karen Wee. She heads up the Lion Befrienders Service Association as the Executive Director. At Lion Befrienders, she has helped to develop and deploy many solutions for fast innovation and digitalization. So thank you for having us, Ms. Karen Wee. So James and Karen, thanks for taking this session. We have a tight agenda, and given the huge experience that both of you have, I'll just dive straight into the questions. So for those of you who don't know, Karen here, in Lion Befrienders, they handle many different types of solutions for caregivers as well as the elderly. But before this, she was working in the government in a few hats. And because of this, she has deep experience knowing about the policies that govern elder care as well. So with this, Karen, I'd like to ask you, could you give us an overview of the elder care landscape and the policies around it?
Hi. Just checking the mic is working. All right. A very good morning to all of us here today. Now, thanks for inviting us over to share. And we're very excited because we do need the future of our country to have people like you to be able to create something to push the boundaries forward. So thank you for joining us. The second thing is, while we create all these things, it cannot be in isolation. It has to be systemic. Now, why are policies important and what are the policies? I think the why is very important. Primarily, we're looking long-term. Few. One is social. Two is economics. Why are we using technology, especially with elder care? Why was Lions Befrienders the first in the whole elder care and social services to use AI, especially AI in mental health, then subsequently dementia and the rest? We have more than 50 research projects as of last count, almost 6 months ago. That is 50 research projects, excluding the projects with the students. These 50 research projects are only with the professors or the lecturers and above, including some of your provost. And this is not just locally in Singapore, the 6 autonomous universities, but we work also with overseas universities. Why? Because we believe the future is here. The future is in your hands. Therefore, we are happy, and we have the largest number of test beds, or pilots we call them, whether at national level, in national government ones, or in the local ones, in the elder care space, of elder care in the community. So sharing the policies, there are two primary ones from what I understand. Of course, from different perspectives, there'll be more. One is social. All of us know that by 2030, 1 out of 4 of us, Singaporeans, residents in Singapore, will be above 65, sorry. And then come 2040, it should go up to 1 in, will be 1 in 4, yep. And then the numbers are going to set to grow even further. It sounds foreign because I think many of us here, I'm going to reach it soon, but many of you all here are very young. For you, 60 is a very far-fetched number. But what if you have to pay more taxes? What if Singapore takes the way of subsidizing when the seniors cannot pay? Who pays? Taxpayers, right? Where does the government get its money from? Ministry of Finance, from you. Imagine if 1/4 of your population is that age, and many of them go into institutions. A sheer cost of a 300-bedder hospitals with land cost is about 18 million. Annual running cost for that 300-bedder is going to be a range of 10 million to 15 million per year. What if the family cannot pay? What if the seniors cannot pay? Who pays? Now, you're going to have 1 million seniors by 2030. Imagine an extreme end. That's the numbers going into. Taxation-wise, currently our taxation is about 12% for corporate and personal. One of the lowest in the world. If we go into the state of welfareism, or go to places like Australia and US, you have taxation 40%. It's a huge country. There are lots of resources, lots of opportunity. Singapore is small. Your taxation goes up to 40%. What will come? What become? Many of you will be relocating. There will be brain drain. What's left in the country? The young, the old, and the weaker seniors who cannot move. Who's going to invest in Singapore? So long term for you. Where's the investment will come? Where's your parents going to be? How your future? Okay, so that's a very important thing. It's very painful, but that is what moves us to also, in many of us have made career switches, we have joined the elder care service to move them fast enough so that we have more seniors aging at home. Which means to say many of them will die at home, but have the best quality of life, empowered and contributing, right? So with that, the policy also has shifted to basically Healthy SG, H-Well SG, as well. Now you see the integration of care in Singapore. Okay, one is you have population health. Everyone be healthy from now on. Okay, and for seniors, we try what we do, 60 already, right? So they get themselves socially, emotionally, mentally, physically, spiritually, financially, having micro jobs, and also the environment to be healthy. Okay, 10 minutes for both of us, so I'll make it quick. All right, so for all these policies, that means the translation of these policies means that how are you going to get seniors to use technology to age well at home? Now, LB has started that in 2020. Today, we have also progressed and also moved into super apps already, which we also welcome any of you to test out and also to come in. Now, for the question about the policies translation, what is important is to understand, one, the system. Are there many other competitors or similar systems? Why should you be different? But before we go there, you have to take also consideration, like what Hong Yi mentioned. You need to know what are the issues in the community, what's the context. Understand your clients first. Then also come up with the issues. Do you use a lot of UX, UI? We do a lot of test bedding. And most importantly, in LB side, we have 13,000 seniors. our aim and our strength is actually to change the mindset of seniors to adopt your technology. Seniors in 2020, we have 6,500 of them. Most of them are rental flats. 80% cannot read or write well, and yet they could adopt technology.
Karen, I would like to touch on that point. So you notice that Karen, she gave an overview of what happens with elder care and the impact it has on society in general, and how the policies have shifted to deal with that. And Karen also touched on the app that Befrienders is building. How did you, Karen, how was it like translating the app on the ground? Were there any ground problems that you faced when dealing with elder care?
Yes, especially for seniors who are more illiterate, the fear of teaching something new means that they have a shift, and also the first important thing is to understand what is the resistance. The resistance primarily is about insecurity, or not sure if they touch something, everything will go wrong. So we have to do everything to basically bring the horse to the river and also guide them to drink the water, okay? So it's a change of mindset. That part LB can do. But the tech that you have must be intuitive and must, like what the rest said, solve their problems. If you can't even solve the day-to-day problems, what use is the app for? Another problem we have is now we face in the other direction. A lot of the apps are very superficial. What do we mean? Because there are just too many apps in the same category solving the same problems. Now, we will ask that all the apps eventually, okay, so for us, we operate in 3 RHS. So we work 3 RHS. For us, it becomes easier because in each RHS, we can also allow us, the seniors in each category, because we operate across different areas. For example, the Western Zone, we will use NUHS. So we can guide and or download the apps for them from the NUHS. We won't download the SingHealth app for them. So that part, we managed it back end. And also because we have super app platform, so it can come in. Now, the other resistance is actually for us, making it simple for them, making them understand. Now, we don't talk about seniors who have low education. Bulk of the seniors are actually educated seniors, at least O levels and above. Now, why will they resist technology? 1 is because they don't understand. 2 is too many. 3 is, what if there's a lot of scam? So all these are considerations that switches them off now. There's the issue of scam. So we work 2 ways. Everything is about moderation. So in terms of the mindset shift, the advocacy on the part, we will handle on the ground. Okay, that's for Alliance Befrienders. In the community side, we are working also in ICCP, okay, Integrated Comcare. In LB, we'll be taking the lead for some of them. So we'll be pipe it through to our other partners in the nursing homes, in the dementia daycare, etc. Okay. Ultimately, it's about full integration of all your systems touching different parts. Imagine there's a river flowing down to the ocean. The river has 3 parts: upper part, midstream, and downstream. The technologies you have can touch any of these streams. Upper stream technically is seniors staying at home, aging at home, okay, in their own house, etc. Midstream could be daytime, they go down to nursing home, daytime they go down to daycare, dementia, end of life, as well as nursing homes will be downstream. And of course, there's also another stream from the hospital. Both streams must also integrate fully for the elder care going to the river. So that is something that we need from your different technology that touches different parts. Okay, I think I should let James talk some more. Yeah, he is also very, very knowledgeable. He's a great partner of LB since 2020.
Thanks, Karen. Actually, I was very enthralled with her sharing because she touched on really important points when you guys are building technologies. In her super app, she encompassed many different touch points, and it's not just one app dealing with one thing. She kind of had this ecosystem to try to address many different points which the elderly and caregivers face. And so with this, with this segue, Prof. James actually teaches gerontology in NUS, and he co-designs a lot of solutions. With this in mind, right, are there any tips that you have with regards to building such solutions that you could share with the participants here?
Yeah, okay. Thanks for the very kind invitation. But I must make a clarification that I don't actually teach gerontology. I teach gerontechnology.
Sorry.
Gerontology is the humanities of aging, right? The social science and humanities. You have geriatrics, which is the medicine of aging. And gerontechnology, I would say, is the design and engineering of for aging, right? So over the last few years, we as part of our course, we get our undergraduates to go out, partner with different agencies, understand the problem on the ground, develop solutions, and in fact, some of the solutions eventually became products which we sell, right? And some of it we actually sold to LB. Anyway, so when we talk about technology, first of all, I think we need to understand the space of the technology. And the way I see it, you can imagine 3 axes, right? So there is one axis on the care level, right? So as what Karen said, ranging from very active seniors going to the AACs all the way to seniors requiring palliative care, right? So different frailty level, different care level. And then you have another axis, right, that looks at whether the solution is organization solutions or whether the solutions are individual solutions, right? Is it a business product or an enterprise solution or a consumer solution? And then there's one more other axis, which is the type of solutions, right? Whether it is a digital solutions, which I think, the talks has been largely focused a lot on digital solutions, but then there's also that device solution and also service solutions, right? So if you look at things from this 3 axes, you're trying to figure out, right, where do you want to park your solution in, right? So, that understanding of that space is a very important first point. And then when you actually come to, working out a solutions, of course, many of you would have learned the design thinking process, right? And you would know that the first part is empathize, right? The E part. So that, I think, it is very critical. And a lot of people who designed technology, right, look at it from the lens of a young, healthy individual with no frailty, and you try to conceptualize and understand what a senior is like. But I would say that a very important point is to really get down to the ground, to really talk and interact with a senior and actually do co-design together with them. So that itself, I think, is also a very key points. Then we also need to understand, right? Once you empathize, you come up with a problem statement, right? So the key thing about the problem statement is, yes, you can identify a gap, but is the gap too wide for jumping, right? So if, let's say, if you identify a gap that is very narrow, and that is, an organization or individual can just jump over it and, get on with life, right? Perhaps that gap is not really worth pursuing. So you probably need to understand, because you might do a solution for a senior, but the senior said, I can live without your solution. I can find other ways to circumvent it. The same for organization as well. So that, I think, is something to worth considering, the gap in the problem statement. And of course, as you come towards coming up with a solution, always, I think it's a great strategy to think about the lean development approach, right? Whether there are existing open source technology or cloud-based solutions that we can tap on instead of reinventing the wheel. There are also many other things that I can talk about, like, I actually put down all the points from my thoughts, right? Like design for scalability and cost accessibility. These are also very important points. And, but I must stress, because time is running short, I can only talk about things in point form. The last but very, very important, as we look at developing solutions for seniors, right? I think it is important not to leave the human dimension out, particularly not to look at them as a endpoint that we solve problems for them, but to really build relationship and understand them as individual and enjoy the entire process. Because through them, you develop trust, and from the trust, you get them to, work together, and then the solution really will come alive. And then you find joy in the entire process. Yeah.
So you notice that James covered the focus that you should have. Firstly, you don't want it to be too wide or too narrow, but at the same time, you don't want to develop something that's already out there in the market. And that's why understanding the local context and what's already out there is so important, like doing your market research. James, I'd also like to ask you, we were talking about the challenges when it comes to developing solutions for elder care, because the payers in elder care tend to have limited budgets, and also the market that we are in, Singapore being a little smaller and having the younger neighbors around us, what are some considerations we can have when we're trying to develop something for payers with limited financial abilities?
I don't actually have a very, very good solution for this one, right? But because I can really think that, there is actually quite a number of significant challenge, right? First of all, when you develop a solution, you need to find seniors or organizations to test. There are some, especially if you are going towards solutions for aged care homes and things like that, they might have a lot of different protocols and processes that you need to, in order to go in to do a lot of testing, and then you need to get buy-in from the seniors themselves. And then, of course, there's an issue of funding and investment because this is such a niche market. Where are you going to get the money? And also, like what Aris mentioned, there's a very small local market coupled with a very small budget within the small local budget. Of course, we can always look at going regional, right? There is opportunity, although our neighbors are relatively young. I spoke to a student in my class who is from Indonesia, and she said that, they don't really talk about aging so much in that country because, generally the population is very young. But that doesn't mean that, we don't actually see that as something that is not worth pursuing, because I think the population is going to grow in the next 10 years. But I think that the key challenge we also want to consider is, the competitors, right? Because if you look at not just our neighbor, but further up north, right, you have a very, very competitive market. You can see, last year I went to the HealthTech showcase or the innovation showcase in Hong Kong. You can see the sheer number of companies, developing image processing or image recognition systems for fall detection, right? Sheer number of companies in the Greater Bay Area. So I think that there is a lot of all this competition. And of course, then how do I scale up, right? How do I scale? What is the manufacturing cost involved? So there are a lot of all these different hurdles. So I don't actually have a very, very good solutions for all this. But I would say that, yes, I think perhaps one of the key things you might want to consider about, right, is, yes, the market is so saturated. Don't just go in with yet another app. Don't just go in with yet another fall detection system and all that. We have to start thinking things in terms of blue sky kind of ideas, right? Earlier on, before this talk, I was chatting with Karen outside, and she was saying, we need to find the next Elon Musk in Singapore, right? People who dare to dream blue sky kind of stuff, and who can actually have ideas that no one else, because otherwise you're going to create another fall detection system to compete with those companies in the Greater Bay Area. Okay, so so how do we do that? Well, I think a large part maybe perhaps really go down and seek understanding from the ground, and I think that is very, very key and vital.
Karen, do you have anything to add to that?
Okay, thanks. Adding to it, I believe, Silicon Valley was not built overnight. It took decades. But we're also sending our very best to Silicon Valley. Why I share that? It's because don't think that Singapore is small, and don't think that Singapore cannot be a gateway. We host a lot of foreign delegations bringing their tech people into Singapore. So the reason is because LB has 13,000 seniors and with 150 staff. So what I mean is that we have 13,000 seniors across 3 RHS and also different 10 centers. Why? So we're able to do test bedding of seniors in different profiles, etc. And we're doing that. And it also shows that technology has improved a lot. We have seen a lot of great leap since we came into the space in 2020. And really we are considered almost the first one in elder care to do so. Now, a lot of technology actually come from people who are dreamers. You have a dream. And who's to say the next Elon Musk will not come from here? And don't forget, the big companies are buying up the smaller companies, acquiring them, paying them well. If you have a dream that can be executed, how do you think Facebook, all this thing come about? Okay, they were acquired. Of course, I know AI, etc. has already, there's some issues now, but you just need to be faster, smarter, more in-depth. Think beyond your box. Think out of the box to push the limit, to know what is needed out there in the space and create. Honestly, early on I was telling them, because they were asking, what would you want to consider sharing the rest? I said, really, the sky's the limit. You're only limited by your own imagination and your own daringness. Because, and of course, funding. So funding-wise, if your product is good, there is no issue about funding. Where do you think LB gets all the money to do the support? It's not from Ministry of Health, whom we report to, because they have to care for the mainstream. That is the baseline. Okay, but there will be people who may be able to invest in your dream. There are VCs. I know the number of VCs have scaled down because the product failure rate is very high. A lot of these products came out with good ideas and then fizzled off. It wasn't able to go in depth. Therefore, the sustainability, the depth of you, it's like having paperwork. Okay, how do you make sure that your work is very rigorous and in depth? You must understand the people you are serving. Who is your identity? You think, what is your business model? How are you going to scale? Check all your criteria properly. Okay, where is it going to be? And is Singapore going to be launch pad for you to go into the region? Okay, like countries. And I share this. I mean, Indonesia is huge. Yes, it's a young population. But Indonesia won the award in Aging Asia. They bid our system. Actually, their system is because they were using mobile. They're using humans to serve the seniors in the areas, cities of Bali and Bandung. So that one with the national Jokowi's government supporting. It came from the coordinating ministry people. So what happened is that they were young officers coming back, sent overseas to to US, etc., other parts of the world. They came back, PhDs, etc. They came up, not the idea, they got the coders to do it. And then they managed to get midwives and nurses and everything and allied health into the villages of Indonesia. Indonesia is a young population, but the size of the seniors is far bigger than our own population of 6 million. So imagine, a world everywhere is going to be a super agent. When you have this product, it's not just about Singapore. Singapore's so small. Okay, come 2030, we're 1 million seniors, but the world population of anyone above 60. If you can understand them, of course, cultural context is important, right? So you need to understand local context, cultural context to adapt your technology. But like music, it's universal. Who is to say our technology cannot be universal? Aren't you using Google? Are we not using IoTs? Are we not using Baidu? Okay, are we not using TikTok? Isn't that global, universal? It's a universal language, a universal platform for you to share. So go beyond, think beyond. So we always say in Chinese, 后浪推前浪. The waves that come beyond should push up the earlier waves. So the future is really in your hands. Thank you.
Thanks, Karen. So, in the interest of time, could I just ask the both of you, probably from Karen first, to share one thought to our audience on how they can innovate for the elder care?
The sky's the limit. It's in your hands.
James?
I don't have such a short one, but slightly longer one. I mentioned design thinking process, right? I think all of you perhaps may have learned it in school, right? We have the the emphasize, the define part, the ideate part, prototype part, and then the testing part, right? Maybe I would like to suggest to consider adding one more thing to it, right? Which is perhaps contextualize part. One other additional block diagram to it. To understand, once you have that, once you empathize and once you come up with a problem statement, right, to be able to then understand the context of your problem statement and all the other existing solutions that are out there, and not then reinvent the wheel. So what I'm saying is, yes, you might go through the whole detection, you might go through the whole process to say, hey, elder care, seniors falling is a very big problem, and therefore I come up with one solution, which is a fall detection system, and then I prototype it, and then I came up with a solution to it. Yes, you can go through the entire process, but yet at the end of it, you are just going to produce one out of the many, many different solutions. So do consider, this is also something I discussed with Karen earlier on, to understand that context of the solutions so that, you will not be just another solutions provider out there, right? In that very competitive space, right? Yeah.
Thanks, James. So in the interest of time, we won't be taking any Q&A, but later on during the networking and the tea after this, you can catch both Karen and James. In fact, doing an open call for them, Karen is looking for test beds to, if let's say your solution is something that kind of is up her alley, right? She would like to test bed with you guys. So feel free to catch them after this, right? So thank you, Karen and James. Thank you.
Thank you.
Thank you.
All right, thank you, Dr. Carr, Ms. Karen, and Aristotle for the insightful session. Now, we are going for our tea break. Are you all ready for break? Don't want to go break. Okay, let's move on. Okay, we're going to go for a quick 15 minutes break. All right, help yourself to the refreshments outside. Okay, at the same time, again, we do have networking bots that are stationed outside. So if you are teams looking for individuals, or if you're individuals looking for a team, write your details down on the post-it notes and stick them outside. And one more thing before you leave, if you have not yet registered yourself today, please do so at the registration table outside. We are going for a 15 minutes break. I'll see everybody back by 11:30. Thank you. All right, welcome back, everybody. Welcome back from the break. Thank you once again for joining us for Health Hack 2025. Are you all ready for the second half of the program? Oh. Seems like only the speakers are ready. Are you ready for the second half of the program, everybody? All right, now, next up, I'd like to invite Ms. Junus, you co-founder of Glorious Care, to share with everyone how technology can enhance, not replace, humans' connections in elder care. So please join me to welcome Ms. Junus up on stage.
Thank you. Hi guys, welcome back from the break. I think first of all, to start, can I just get a show of hands? How many of you have actually been in nursing homes? Like, just a show of hands. And how many of you have actually taken care of a senior? So I want you to picture this. You're standing in the ward of a premium nursing home. They are known to, adopt technology. They are known to have like the best care staff. And you just enter the ward and you see this old lady who is actually lying on the medical bed, and she's actually clutching to the side, the side rail, and she's kind of like looking at you as she's lying down. And like, what do you expect? What do you expect someone like that to say? Does anyone have any suggestions? Anyone? The people who have been in nursing homes? Happy moments. Happy moments. So this was my personal experience, right? And I was in a nursing home because I did my studies in gerontology, which is the study of old age, every aspect of it. And what I heard next was, not necessarily something that I really expect to hear, or, because I was like younger and more naive then. And she said in Mandarin, and she said like, 小妹,你可以叫我妈咪吗? And in Mandarin, in translated to English, is like, little girl, can you call me mom? And that got me thinking that, you're kind of in this nursing home is supposed to have the best care. It promises the best care for care recipients, for the seniors. And yet you have someone who's sitting there. She probably has all her medication. She probably has fantastic medication compliance. She has probably her care plans has done well for her. But she's there. She's basically asking the first female who walks through the door and said, can you call me mom? Because that will somehow like soothe her emotions, something like that. And that actually really made me think about how we actually design for healthcare is important, because I think a lot of what we talked about early this morning is about efficiency, it's about, how do we ensure that care is given to seniors at the right time. And very often we ignore the part of, what does the patient actually want? Which is why, I talked to Nidhi earlier on, because she raised a point, a very important point, that it's very important to think about what do the seniors actually want. And so this was just my, my one-off experience. But when we look at the global headlines, this is all pretty recent. So in Bloomberg, there's France, where it's like the nursing home where there was a scandal of elderly abuse. In China, there was a guy who was like beaten and tied to a wheelchair by his carer. Papa Inc. is a $1 billion US company where they basically are like a task rabbit for seniors. Like you go on and say that, okay, I'm a young person, I can help a senior carry groceries, and then the senior actually signs up for that. So they are a $1 billion company, but then they also have to face like certain like abuse scandal issues. This was actually just this year, just over Chinese New Year in Malaysia, where a doctor actually said that there's this habit, or rather like, they see an influx of seniors coming into nursing homes because their children put them there so that they can go out on holiday for Chinese New Year. And then, of course, back in Singapore, we obviously have isolated seniors and also overburdened caregivers who are linked to elder abuse cases. And just over Chinese New Year, there was this like coffee chat where there's this person, he actually works in a home care organization. He was super burnt out, and the person was actually asking why. And he said, you can't believe the frustration he feels because it's Chinese New Year and he's calling up the children of these seniors, asking them, can you come and visit your mother or your father, and they don't come. So the reason why I mention this is because, when we think about designing for this space, we need to think about all the various stakeholders. There is the elderly, there is their immediate family, there are the caregivers who care for them who are clearly very burnt out. And when we look at WHO statistics, and obviously I use AI to draw out all these things. According to WHO, they said 1 in 6 age 60 and older actually experience some form of abuse. But more interestingly, the statistic that I found surprising was that 2/3 of staff actually admit to abusive behavior towards residents. And this is not, it's not talking about like demeaning the staff, because when I studied gerontology, a lot of my batchmates actually all work in the care sector. And you kind of can see a difference between the people who are new to care, who are new to elder care, and the people who have been there for like a much longer time. Because I don't come from the space, I come from the background of technology investments. And when in my very first class, we were given case management, and the case was basically, how do you deal with a senior who is demented to the point where she is very fearful of the world, and she has 6 locks on her doors, and she doesn't want any care worker to come in. She doesn't want even her family to come in. And when I, looked around my table for answers, because these are all people who work in the care sector, I asked them like, what do you think, what do you guys do? And then I had this response from a social worker who has been in the space a long time. He came into the sector with all the heart in the world, but then he said, oh, we wait for them to die. I was like, how can such a statement come from somebody who's supposed to work in care? But I realized later on that they are actually really, really burnt out. So of course, with AI, given that we're talking about in 2025, there's a lot of talk about AI, there's a lot of talk about how we can actually leverage this technology to kind of automate processes. How can we use this technology to make elder care better? And oftentimes, AI can basically tell you, there's health monitoring, trackables that we talked about earlier this morning, where seniors actually wear them and monitor their daily activities, their blood pressure. They're able to help them detect falls, which is all good, great. Telemedicine, predictive care, being able to diagnose issues before it becomes serious. That is also important. Personalized assistance, I think that's something that's quite coming into the fray these days, where you have AI that helps you with personalized medication and also other applications. And of course, there's a whole host of companies that have been operating for the last 5 years to basically see how they can leverage AI and automation to help in the elder care space. And I want to bring you through some examples. So the first one is LEQ. It's basically this device, this screen, and then they put it beside a senior. And this LEQ will greet the senior and say like, good morning, how have you been? Have you taken your medication today? And obviously LEQ as a company would say that fantastic results, right? It reduced loneliness for 95.9% of their respondents. And then they also said that the senior said, I love it that addresses me by my name, asks how I'm doing. I feel like she's almost like a real friend. So she clearly cares for that human connection that maybe she's not getting in her current environment. And the next one is Paro, which is basically what you see, this seal. It is what is called a robo-companion, and it's been around for years. It's not like a new invention. And they also say that they've reduced social behavior, increased social behavior in 97% of isolated residents, along with many other benefits of making them feel calm, based on the studies that Paro actually did. But when I actually really looked into some of these cases, case studies, I actually really resonated with an observation by an MIT professor, where she says, what's extraordinary to me is that although this lady who was holding this seal in the center of the room was surrounded by people, researchers like herself, we were kind of like, she was kind of like just saying, we were applauding and stepping back and cheering on this senior's connection to a machine that understood nothing. And that made me think about, why, you have a room of 10 people who clearly have the capacity to connect with this senior in some way, but yet we're always assuming that, let's use tech to help, let's use tech to reduce the loneliness of seniors, for example. And so AI is not, that's like the more gloomy side of AI, because when we think about AI, we need to think about what are the, how are we designing it such that it makes it more human, enables care workers to be more efficient at what they do. And when we think about care, like for example, I was speaking to a speech therapist earlier this week. A speech therapist is somebody who obviously helps with swallowing disabilities, and she mentioned that she works with a lot of patients who are end of life, and she has fed many last meals. She's usually the person holding the hands of the senior as they pass away. And I was thinking about the work that she does and the fact that you can't really have technology replace somebody holding the hands of the senior and listening to their life stories and listening to their life words. But there are other ways in which AI can help, and let me just give you a few examples of that. So these are already examples that are already live. So for example, at NTUC Chai Chi, NTUC Health Chai Chi, they basically have this self-guiding robots that basically carry heavy loads of linen, which helps them save more than 4,000 man-hours a year. So typically, somebody working in a care home or facility like that, on top of taking care of the seniors, they also need to manage the things of like the heavy handling of like heavy loads. So before the nurses had to carry over 70 bags of dirty and clean linen to 7 levels of wards a day. So this is an example of how automation can actually reduce the workloads and also the stress levels of caregivers, so that they can be more present for the people that they are actually caring for. The second one, is also in Rensis Ang Mo Kio branch. So this is actually geofencing, where typically, a big problem with dementia seniors is that, there's the issue of them wandering away. So with geofencing, instead of care workers now spending more than 2 hours looking for a lost senior, with geofencing, they're able to locate seniors within 10 minutes. And for us, one of the ways in which Glorious looks to reduce the care burden on care workers is also reducing their time spent on administrative reports. Because right now, for one home care deployment, a care worker would go home and spend 30 minutes for each home care deployment. So it's sort of like a teacher, they're kind of like, after a whole day of being overworked and kind of being there for the seniors, they kind of had to go home and spend another few hours writing care reports on, what it was like. At 8 a.m., I went to this, Uncle Lee's home, and this was the medication that was given. This was my observations of the senior. This is my recommendations for the next steps. You can't just imagine them at 8 p.m. going home and trying to recall this information. So with AI right now, we're able to cut down the time of reporting from 30 minutes to less than 30 seconds. But my main point is that, certainly AI cannot fully replace human connection. And the reason why I wanted to talk about how do we stay human when it comes to designing for the next generation, I think it's very important, especially for HealthTech. I think we cannot underestimate how important it is to really sit with the people that we're designing for, especially given that, this is a crowd that is, a much younger audience. And I also wanted to say that, we have mentored for, other elder care hacks before. And when we look at the output of the groups, and these are people, it was SMU students back then, the teams that really stood out, or sometimes the people that really stood out, they were caregivers themselves, or they're people who actually have really sat down and really just, you just sit there and just be silent and just observe how people talk, why they act the way that they act. And once that person has that perspective, it actually cuts through everything else. The empathy for the user is way more important than how well thought and how academically well researched your solution is. Because you really need to put it in the hands of the user and observe how they actually use it. So I think that's basically like I implore like all the teams for HealthTech to, when you're actually designing, user empathy is very important. It's very important to sit with the people that you're designing for, or it's even better to have someone on your team who actually understands very intimately what it is like to be a senior with chronic health issues. Because as I was talking to someone earlier that day, when somebody is as older, is diagnosed with, let's say, a terminal illness, many times, the things that they're thinking about is not how efficient healthcare systems are. It's not at the front of their minds. They're thinking about, what can I do in the time that I have left? What are my emotional needs? You realize a lot of the things that they care about is not about medication compliance. It's not about all the things that the healthcare system pushes on them. So that's why I think that my message is to really design with the end user in mind, which in this case is the seniors. Thank you so much.
All right, thanks, Ms. Junus. Do we have any questions for her from the crowd? Any questions? No? If not, please, round of applause one more time for Ms. Junus, everybody. Thank you so much. Thank you. No, there's no multi-break. You get one. All right, now please join me to welcome Mr. Dean Andrews, Head of Developer Relations at InterSystems. Now he's here with us today to impart key lessons in healthcare innovation, practical next steps, and tips to maximize your hackathon success. So discover how to leverage cutting-edge AI technology to power innovative healthcare projects and explore opportunities to elevate your ideas with the InterSystems Startup Program. So please, a round of applause for Mr. Dean Andrews.
Thank you. Let me be the first to say good afternoon to you. How about a round of applause for the organizers of this very cool event? So again, I'm Dean. I'm from InterSystems. I'm very excited to be here. It's my first time in Singapore, my first time at NUHS, and it's been an absolute blast so far. Thank you all for participating in this event. It is exactly these types of events that bring real innovation in healthcare, so thank you. Over the next few minutes, I will tell you a little bit about InterSystems, and I'll share some of the things we've learned about healthcare innovation over the last 45 years, and hopefully they will help you with your hackathon event. I like to tell people that InterSystems is the coolest company you've never heard of. We are a global technology company. Over 1 billion patient records around the world every day are managed on InterSystems technology. Our technology in healthcare is used literally around the world. We are headquartered in Boston, Massachusetts in the United States. That's where I work. But we have offices all over the world, including right here in Singapore. We have a startup program and a venture fund, which I'll mention a little bit later. And we're also hiring, so keep that in mind when you're thinking about job opportunities. The title of this talk mentioned that we power the world's most popular health applications. And this is just a sample. These are not all of our customers, but there's some. The top 3 rows are either Singapore-based or local to this region, customers and partners we work with. Shout out to Marymount Labs sitting right there that'll be speaking right after me. At the bottom on the right is the Veterans Administration of the United States. It is powering the patient record management of millions of U.S. military veterans. In the center, InterSystems technology powers the National Health Service of the UK. Again, millions and millions of records there. And then the last one is the Epic Electronic Health Record System. It is the world's most popular electronic health record. It is built entirely upon InterSystems technology. And again, I mentioned most popular healthcare applications. The Epic solution is one of the most used, most scaled, most data-intensive applications in the world of any industry. So it's something to keep in mind there. We have built an innovation pathway, we like to call it. You're all in it right now because the first stage of this pathway is our global hackathon program. We participate in the biggest and best hackathons in the world, and that's why we're here today. And a shout out to Olga here in the front row. She runs our hackathon program. So there's a lot of connections you'll hear in my talk that echo some of the things said by all the great speakers earlier today. One is that it takes many ideas to get the ideas that actually change healthcare. And that's part of what we're doing here. So we sponsor and participate, encourage people working in hackathons, and then we recruit the best to join us if they want to continue, if they want to keep developing, if they want to build a business or startup around it. We encourage them to join our incubation and acceleration programs, and we have done that from many hackathons. And then we teach and educate the startups there on healthcare, on technology, on the business of running a startup, and then we help them go to market. One of the speakers earlier today said that it's only successful if the solution is used by people, and we know that. And so that's what we try to do by bringing people. We bring startups that are working with us, that are in our program, to the biggest healthcare conferences in the world, and we get them pitching in front of thousands of people. We introduce them to partners and customers to help them get real traction for their business. And the program has been going fantastic so far. If you want to learn more about it, there's the URL startup.intersystems.com. You can read more about it there, including our corporate venture fund. We have a startup incubator that we run every year. It's 4 months. It's that first step that I mentioned of going from hackathon into incubation and acceleration. We have hospital partners. It has startups from all over the world can participate. They're working in many different use cases in healthcare, and it's virtual. You can work from anywhere in the world. And one of the prizes for our challenge in this hackathon is you are admitted to this incubator this year. There's no fees, no costs. The incubator is packed with sessions on healthcare, on technology, on running a startup, and many things. It's very powerful. A lot of startups that have gone through it have great things to say about it, and it's the first place prize, including a cash prize, for this hackathon, for our challenge. The technology that we're showcasing in this hackathon is our generative AI technology. It's just one part of our solution. We have a very powerful data platform. Some of the features are listed over on that banner there. And we've added, very organically, generative AI technology. Here is just an example of a startup using it for a retrieval-augmented solution that is actually using our InterSystems documentation in a RAG pattern, they call it, and so that you can just query our documentation in natural language and get the answers directly from that. There are many more use cases. There are many reasons to use this technology in healthcare, including if you just go out to large language models alone, it is very unlikely that healthcare organizations will adopt your technology. There's patient data privacy concerns, many other safety, accuracy, a lot of different things, but you can use those large language models in conjunction with technology like ours that creates this RAG pattern that keeps data private, safe, but allows you to take advantage of all the power of generative AI. To learn more about this, stay to the last talk today that talks about our challenge intro. Here are some quick things that we've learned. One, again, echoing what people have said earlier, is ideas are great, but pick a problem that your idea is solving. That is the way to get traction. The people working in healthcare, the patients that are served by healthcare will find meaning in your solution if it's actually solving a problem that they have. Another thing echoed from speakers earlier, be creative. Don't limit yourself. Just come up with as many ideas as you can before you settle on one, because you have to open your mind and think out of the box, as people said. Code talks. That simply means build a prototype, especially in this hackathon where you have few weeks, not just 24 or 48 hours. You have time to actually build something, and that will be compelling to everyone. The judges, people interested in this type of solution, the healthcare industry as a whole. If they see what you're doing in action, demonstrated, it moves people. Ask for help. If you take on our challenge, we have mentors that will help you virtually all around the world for the next few weeks. You do not have to do this alone. And finally, work as a team. We've done many hackathons, and it's important to let the entire team contribute and deliver the strengths that they have. It always makes for the best outcomes. Here's some advanced topics that are actually touching on people that are maybe thinking of taking this hackathon idea and doing more, developing more, maybe establishing a startup. These extra credit topics are: who would buy what you've created? It's just something to think about. You are not going to sell a solution, a generative AI solution that replaces radiologists to radiologists. They won't be interested in that. So just think about who buys what you're creating. Also, how does it fit into the healthcare system? Who uses it? When do they use it? Why do they use it? What does the competitive landscape look like? What others are working on this problem, either locally or internationally? What research supports your idea? And because healthcare systems differ around the world, think about the regulatory concerns, of how your solution works in the regulated environment. What credentials do you need? What certifications do you need to actually be approved to work in that environment? And finally, this is my last slide. This is our challenge. We're fully aware of the tracks of value-based care and Silver Age generation care, but you can use this solution in conjunction with either of those tracks. You can build generative AI solutions using our technology that work with solutions in these areas. We have cash prizes for first through third place, and we have that incubator thing. Again, so the incubator, we have many more startups apply every year than are selected. And we have a whole selection process, but one of the elements of the first prize of our challenge is you bypass that whole selection process and you are in this incubator if you wish to be. That's all I have. Thank you very much for listening, and we can't wait to see what you build.
All right, one more time for Mr. Dean Andrews, everybody. Now, if you have any questions for him, okay, they have a booth outside, so later on during lunch, do feel free to approach them to ask your questions. All right, next up, we're going to move on to another panel session. So first, let's get the chairs ready for our panelists. All right, first up, I'm happy to invite up our moderator, Dr. Zachary Yeo, Director of Digital Advanced Technology Accelerator, please. And I also like to welcome 2024's Health Hack winning team, Marymount Labs, and their co-founders, Mr. Lazarus Chok and Mr. Zacchaeus Chok. Now, you're going to hear from them about why their hard-earned lessons of building a startup in healthcare and why hackathon success is only the spark, not the fire. Take it away.
Okay, hello everyone. Thank you all for joining us on a Saturday morning. I think amazing lineup of speakers so far from InterSystems, and thank you so much for flying all the way down from the United States to come down and join us today. I think today we are very fortunate to have back the winners of HealthTech 2024 here. And it's just to learn a bit more about their journey from HealthHack 2024 to building up Marymount Labs, which is their startup today, and raising pre-seed. So the first thing is what led you to join HealthHack last year, and how do you find the competition compared to, I think, other hackathons or other programs that you have joined?
Yeah, so hi, I'm Zach. What led us to join HealthHacks was really just a simple email that was blasted out to all NUHS students. So I took the opportunity. But for the second question, what differentiates this from other hackathons? Well, I've been to a fair share of hackathons throughout my undergraduate days. I think what really differentiates this is the format. So all the other hackathons that I've been to usually compress the timeline into 24 hours. And what ends up happening is you can have wildly creative ideas, but these ideas generally don't have any commercial mileage. These products you never see the light of the day. Whereas if you look at health hacks and how they spread it out over a month, where you get multiple touch points with different people in the medical community, what you end up with is a more mature product that could resonate with the healthcare community. This product may not necessarily see commercial mileage, but at least there is a higher chance of it eventually being adopted by someone within the healthcare community.
Okay, so how was your journey like after HealthHack then?
Yeah, maybe Zachary, you'll share more about this later, but I think one fortunate follow-up to the HealthHacks 2024 was that we were supported again by this excellent team here to join the accelerator program towards the end of 2024. And that's when we really got deep into talking with healthcare groups in Singapore, GP clinics, and even partners in the US. And that deepened our understanding of what it means to build for the healthcare space. I think that supports the mentors and the whole community around that really fueled our growth.
So I think we went a bit too far. So could you mind sharing what you built for Marymount Labs during HealthHack 2024 and how it was applicable and how did it change over the time since you, from then to being part of the accelerator?
So our idea for HealthHacks was really how we could automate the health coaching process when you're trying to convince a patient to maybe take a vaccination or go for a certain cancer screening process. I'll talk more about this later, but at that time, we were thinking about how we could marry large language models with existing social frameworks, in particular the health belief model that was able to model the motivations, the psychological motivations of individual patients based on what their incentives are to take a certain health action, what their barriers are, and what their existing vulnerabilities are. And so we presented a prototype that merged large language models with this framework. And we were able to show and simulate a conversation between the bots and a patient who is hesitant about taking a cancer screening process. We decided to go down this route of automated chatbots, But once we started to speak with different healthcare stakeholders, we realized that this technology was just too far from them. It's too detached from reality. What we ended up building in our early days for our MVP was a WhatsApp campaign builder that was able to send structured messages, not LLM-generated messages, to patients. And that really, I think, helped with any concerns that they had over trust, safety, and privacy.
Yeah. So, what are the challenges you faced from building then? And I think finding product market fit and commercialization, right? Because there's a huge jump from a hackathon idea and MVP to commercialization and getting revenue from the people you serve.
Yeah, I think to answer that, maybe we take one step back. If you all haven't already noticed, we both share the same surname. We're brothers. And how this whole journey started really was during COVID, when we were sharing a room at home and we couldn't leave the house. It was circuit breaker, and we were forced to spend time together in a good way. And we started working on projects. And over the years, we worked on many different projects. But one of the insights that we landed on was that to succeed, you really needed to understand a particular industry really well down to the detail. The litmus test for it is being able to perform that same role a normal worker would, say a healthcare administrator or a nurse counselor, and be able to perform that role. And then you can start be working on solutions for it. So one of the biggest challenges that we did face through this journey is, how do we understand the healthcare system? Our background is more in engineering and data science. We have rather little understanding of the healthcare industry. So we really had to go out there, talk to doctors, talk to nurses, talk to healthcare administrators to understand the problem deeply. And the truth is, we'll never understand it completely. So it's a continuous process.
Okay, there's an iterative process through that. How important was the ecosystem to supporting you to achieve that goal? I mean, you're also part of InterSystems incubator as well as the data platform. How did it help you and grow and journey?
So I think mention a bit about InterSystems. So even before HealthHacks, I participated in several InterSystems hackathons based in the US. And I think what was helpful for me is to understand the breadth of the technology and why use InterSystems technology in particular. Of course, if you're a developer, there are many other technologies out there. You can use something like Supabase, AWS, and other technology stacks. But just understanding that there are very specific technological requirements in the healthcare industry with regards to security, encryption, which also means why InterSystems exists in the first place, I think really helped me when I thought of technical solutions to problems within the healthcare industry.
Yeah. And I think on the non-technical side of things, having that community is really critical for the healthcare space, because our primary kind of like beachhead market is in primary care, so your GP clinics, family medicine clinics. And even in primary care, which you think as a normal lay person, you go to the GP doctor, you sort of understand the workflow, but that's really not true. Even in the primary care space, we ended up talking to solo GP practices, healthcare groups like Fullerton, Parkway Shenton, Raffles, and then you have the primary care networks, which is another layer on top of it. And then there's the government, the kinds like policies and the regulators around that. And then you have the technology partners, there's InterSystems, and then there's the CMS providers, 20 odd of them working in the GP practices, and also the MOHT Synapse side of things. So it's an extremely complicated ecosystem. And that's just our primary care, and not even talking about acute hospitals and so on. So having that data platform to be able to work through all these things is incredibly helpful.
Okay, so I think have any advice to many of the participants here and at home? I think we have about 500-600 tuning in. Any advice of how to win HealthHack? I think there's one part, and how to continue building for healthcare.
Yeah, I have some points on that. Firstly, build a thesis before you're building. I think when we did HealthHacks last year, I think we only spent one day on writing out the code. And when I write out the code, I was just using Python for both the front end and the back end. So I don't think you need to be, a senior engineer to win this hackathon. But that hides, the amount of effort that we put into this hackathon. We spent the better half of a month speaking to solo practices, healthcare practitioners, and some of the mentors within this community. So I think it's important to really understand the why before you proceed with the how.
Anything to add, Lazarus?
That's actually the key thing.
The key thing, okay. So now the theme that you mentioned about why your winning hackathon idea is also a losing startup pitch. That's very, very intriguing. Do you want to share more?
Yeah, for sure. I think to answer that question, it really reflects the journey that we've been on. When we went for Health Hacks last year, the product that we built was an LLM chatbot. It's supposed to nudge you to take a vaccine, nudge you to do cancer screening. But like what Zacchaeus mentioned, that is really far detached from reality, right? None of us will be using something like that. MOH still sends us SMSs to encourage us to go for a COVID vaccine. So what is the intermediary? We asked ourselves, what is that inevitable future? The inevitable future is indeed that large language models will become more pervasive. They will become safer, they will become more reliable. But today that isn't the case. So how do you as an entrepreneur, as a developer, as someone very passionate in this space, how do you pull that inevitable future closer to today's reality? For us, the intermediate step seemed to be, instead of sending an SMS, could we do a little better? Could we send it out as an automated multi-turn conversation? Meaning, it's not just an SMS, but hey, you could actually respond to it. It triggers, relevant messages to encourage you, to nudge you towards taking a vaccine. It sounds terribly trivial, actually. And I think this reflects earlier speakers. You don't need a spaceship of a solution. Sometimes it's just a better, tool. And for us, we built a better tool. Yeah.
How was the uptake, or what was the feedback from the people that used it?
Yeah. So over the past few months, we've sent out thousands of campaigns using our platform. That has helped people remember to take their vaccinations, gone back for cancer screening. We've even seen patients take up, they'll open their WhatsApp in front of the GP clinic and then tell the counter staff that, I'm here to take my vaccine. And the clinics are shocked because these are patients that they haven't seen for months. And so you have very well-intentioned preventive care programs in Singapore, like Healthier SG. And that's great. I think we need more solutions to help encourage the population to take ownership of their health. And solutions like ours has seen good uptake, good reception, not just from the provider side of things, but also on the patient's side of things, because it's something simple. It's something that you don't need to download a new app to use. It's integrated into your WhatsApp already, something you're super familiar with. We've seen, people almost 100%, read rates for our messages, very good conversion rates to come back to the clinic to do services, and we are quite heartened by it.
Okay, thank you very much, Zach and Lazarus, for taking the time back. Please give them a round of applause. I think we are a bit tight for time, so later during the lunch break, do catch them, because if you want to get tips and ideas of how to win this year's Health Hack and be part of both the incubator of InterSystems, to hear more about how the benefit of the ecosystem built by InterSystems and NUS Medicine helped them grow to where they are today, please catch up with them. And after this, we'll head on to the next side of our panel. There'll be a bit of a shift. Thank you guys. There'll be a bit of a shift in terms of timing. We would do the briefing first for Health Hack before we move on to our next panel, our next speaker. So. So I think thank you all for both here, those of you here as well as those at home watching. I think there's about 500-600 of you online watching. Welcome to Health Hack 2025. Thank you all for gracing us today on this Saturday morning. just to share a bit more about what we are and what this initiative is, this is actually started by the Digital Advanced Technology Accelerator. I know it's a long word, but it stands for data itself. We actually hope to increase greater cross-pollination among various individuals. As you know, there are doctors here, there's engineers here, there's software developers, students, business individuals, research scientists. We actually want to encourage greater cross-pollination among all of you to build amazing healthcare products, because everyone here is essentially here to actually build for healthcare. And for me, and both me and Lowell, who are both doctors, we actually feel this is a very meaningful cause, because the main beneficiary is our patients. But at the same time, you have to understand that you need to understand the real world constraints of it, rather than building just because it's a better idea. So this is our various social media, if you want to follow. We have Instagram, we have LinkedIn, and you have our email as well. So you can kind of follow that, and there's a good way to stay connected with us, because I think HealthTech is one of our events. We actually have multiple engagement events as well, together with our accelerator that's coming up in July. So you can actually sign up for that. Maybe your amazing idea. So even all the startups, all the ideas that come out of HealthTech, we actually welcome you to apply for our accelerator, and we actually help you kind of develop and give you feedback on how to improve on that further. This is our Telegram. Please do register this, because I think currently a lot of people who are registered on our Telegram actually is getting up regular updates and feedback. Also for formation of teams, and also interacting with InterSystems with regards to their challenge. You need to be part of this Telegram channel, because that's where we actually will disseminate a lot of the information. Next. Okay. Also, another tool for you guys is the Trello boards. So basically, you can join our Trello boards and sign up. Different individuals will encourage different teams to state what you require. Like, if you're a team of engineers and you want to meet a doctor, there are a number of doctors here. I think from our chat, we hear colorectal surgeon, anesthesia, gastroenterologist. We have all these individuals here already. For doctors who are looking for a team, there's plenty of engineers in the room as well. So so now we're going to go through the format. I think we'll let Lowell cover that.
Okay, Ken. So the key important dates. Anyway, all this is on the website. If you miss it now, you can just go to the website, which you have QR'd earlier. So today kicks off the opening day. At 5 o'clock today, the submissions portal opens. So some of you I know already have been secretly working on your idea, and maybe you're already prepared. So you can start submitting, but they only close on the 15th of March at 2359. Okay. After that, we'll look through all the submissions, and we'll announce the finalists on the 22nd of March. And if you're a finalist, you'll be invited to come down for finals day on 29th of March through a competitive process. There will be a technical judge, as well as a panel of judges. So this is the submission format. You need to form teams of 2 to 5 people. So you cannot join as a solo person. You have to find a team. And you need a minimal viable product by the end of it. To see what's up to scratch, you can ask Zach and Les what they submitted last year. Because if you came out with just an idea, it's pretty hard. How you do it is you upload a 5-minute video pitch onto YouTube. Again, all the instructions are on the website. We should include the following: the product name, the description, this kind of things, okay? Let people take photo, okay. And the two teams, I think you've heard our speakers talk a lot about it already, mainly value-based healthcare, as well as the silver generation. And in interest of time, I'll just click through this quickly. And this is the judging criteria, okay, this is an important slide. So, based on the ideas, you'll be judged on the originality, functionality, feasibility, validity, accessibility, value, scalability, whether it's relevant to the themes that we have, what the impact is, and there'll be a technical judging. So, if you make it to the semi-finals, we'll ask for your source code, and then we'll actually run it by technical judges to see whether it's functional and it's efficient. All right, and of course the prize money is what we're all here for, and the food is that the first place will get $5,000, second place $3,000, and third place $2,000, and this is for each theme. All right, so if your company or your team is good enough, you can submit for both themes, and you stand a chance to win twice the amount. And more importantly, I think we also have a special InterSystems bonus challenge. So later, Julian will be giving us a brief on the bonus challenge. So stick around for that to learn how you can win both. So all the prizes are not exclusive. You can win more than one pot of money. Okay. All right. Any quick questions we have? In the short time, maybe you all just text us on the. Yes, you have a question.
you can use, there's a board outside that people are already sticking things on. If not, you can go to the Trello boards or the Telegram chats. I think for PDPA we can't send the list, so it's more for it's allow it to be more organic. Yeah. Okay. I think in the interest of time, we will actually one of our
Xiaohong. Okay, so the good news is that this year we are. I mean, how many of you joined us last year? We partnered with Microsoft PowerPoint. So this year we are proud to share that besides InterSystems, we are also partnering with Google. So Xiaohong will give us a quick slide on how you can get started with Google Cloud.
Hi, thank you. Hi, good afternoon, everyone. I'm between you and the lunch, so I'll make it short. I just have 2 slides, actually. My name is Xiaohong. I'm from the customer engineer team, the public sector team. Felix and myself, we take care of the IHL and the education sector. So today I'm going to talk about how you can actually use Google Cloud. Sorry? Okay. So as you know, Google Cloud is one of the cloud service provider, and the range of service is really wide, from infrastructures to platform, and then to the machine learning. And Gen AI is probably one of the technology that you heard before. So I'll show you some of this later. And you don't have to start up with a big budget, all right? In fact, it's pay as you go. And we also give you a free trial. So when you use a Google account to actually log into the Google Cloud Console, you'll be given the $300 credits that you can actually apply to the infrastructure services like compute engine virtual machine, right? There's also an additional 1,000 credits that you can actually use for the generative AI products, like large language model, Gemini API, and things like that. All right? So that will be useful when you're actually building something that's based on a large language model. All right. In addition, after the hackathon, if you are thinking of starting your own business and things like that, this will also be a good way for you to start because everything is pay as you use, and there's a free tier, so you can always start small. Okay, I won't talk about the rest of the services. Is there any way I can connect to my laptop and show them the screen? You can't, is it? Okay, then that's fine then. All right, then I'll just move on to the next slides. Okay, so to sign up for the Google Cloud Platform account, basically you can just search for the Google Cloud free trial. Just type in your browser Google Cloud free trial. And then one of the links will actually pop up. Alternatively, you can go to cloud.google.com, and then from there you log into the console with your Google account. If today you have email like john@nuhs.edu.sg, you can use that to sign up for a Google account as well. And then once you click on the free trial, you'll be given the $300 credits, right? So do check the terms and conditions because the free trial doesn't apply to all the products. There are some exclusion. For example, if you're using a GPU, then that will be chargeable. That will not be under the free trial, right? So just go through that. And if there's any question, just let us know. I think that'll be all. All right. Any questions for me?
Well, you can find him later.
All right. Thank you.
Okay. And I think one thing that we are tying up is that so Google will be coming out for finals day, and if they like your use of their product, then they may enroll you into the Google for Startups program, right? Of which you can get up to I think 350K of credits. Okay, next we have Brian from OGP. You heard his big boss speak earlier, but he's here to show you something cool that they've actually built during this month for Build for Good.
Hey guys, my name is Brian, like I think you heard. I'm a product manager in OGP. I think Hong probably shared a bit more about OGP just now, so I won't give you the spiel again. So I'm here to give you a sneak peek on one of the products that we have been building that might be useful for your upcoming weeks in the hackathon, right? Being in the field, we understand that having a prototype is like super important. It is something that you build, something you can hold and feel, you can pass it to your users for them to validate and whatnot. But we also understand that if you have little or no engineering background, a bit hard to get a prototype running and building if you don't know any coding lah. So we built Spaceship to help with that. So what is Spaceship? So Spaceship, so we spent the last few weeks building this product in our own hackathon. So what this does is it allows folks like you, assuming that you have like little to no background in coding, to just generate, build, and deploy full stack prototypes in a matter of minutes. So you just key in, just use like prompts lah. You got an idea, you just build the whole thing for you. Let me just, so instead of like talking about it, let me just show you what it does lah. So you can key in your domain, assuming that you have an idea name, right? I key in something, I think I wanted to build a medical reminder application. So what this does is it's deploying the environment, it's spinning up the place for you to actually input your prompts. So I keyed in a few prompts. I was a bit verbose with my prompt. I got a lot of things I want to do. I want to do this, do that, do that. Just give it a sec. I think I have one more point I want to make. Allow users to confirm it. Yeah, and then it runs. So it puts it in the prompt, and then it basically spins up the whole full stack application for you. I sped it up, but in a matter of minutes, you have a working prototype. I'm not medically trained, so for medical name, I put Panadol, and then I included the doses and whatnot. So basically, you got a working prototype right off the bat, bells and whistles included. And at the last portion, I don't think you saw, but it's deployed on the internet basically, on the government commercial clouds. So you can just copy the link, just share it to your users, and they can just straight away use it. So right now, Spaceship is currently still in beta, and it's free to use. If you're interested in trying it out, and bearing in mind that there's a lot of jank and bugs, so if you're okay with that, do sign up for this. We are, as I mentioned, we are in beta, so we are prioritizing problems and solutions that are related to helping the Singapore government, helping public healthcare clusters in Singapore, as well as public hospitals. So I think if you fill up that form, you can see like we ask some details regarding your problem statements and solutions. If you want, the actual link is a GoGov link here. If you want, if you have any Q&As and questions, you can email us at space@open.gov.sg. I'll be sticking around, I think, at the back or outside. I wore quite a prominent shirt today, so hopefully you can find me. Yeah. Okay, thanks guys.
Okay, thanks, Brian. So the last plug is we are also doing regional this year. So we are having HealthTech in Bali as well next week. So if any of you need an excuse to go to Bali, join us. And this is the lineup of speakers that we have. Our InterSystems is also going to be there. A lot of people in the Indonesian ministry are actually pretty interested in digitalization. So that'll be good to have. Okay. Last plug, please join the Trello groups. Because many of you keep asking about how to find teams. It's all there, right? All digital solutions, okay? Okay. All right. Okay, we go back to Joseph. Okay.
All right, thank you to all of our speakers. Now, next up, we have with us Dr. Joseph Mocanu, co-founder and managing partner at Verge HealthTech Fund. Now, he's here because HealthTech investors look for more than just great ideas. They want investable solutions to real problems. So this session will explore what works and what doesn't, and how to refine your hackathon idea into a compelling pitch. So please give a warm welcome to Dr. Joseph, please.
Clicker? Yeah, thank you very much. All right, thank you everyone. I think I'm yet another impediment to your lunch, although if you pay close attention, you may end up with a nicer lunch. So, had a nice intro. Thank you very much for that. I think with anything in life, you have to take context into appreciation. So, whenever you're listening to advice, always think about the motivations and experience of the person giving the advice. In my particular case, I'm a plain vanilla venture capitalist. I'm out for a certain thing, and there are other people out in the world that have different motivations for investing. You can find investors of all different shapes, sizes, time horizons, risk tolerances, motivations, You have Dean and the InterSystems Corporate Venture Fund. They probably look for things other than financial returns. Probably financial returns matter, but also strategic fit. You'll have people that have certain mission-specific parameters. They may care about that more than financial returns. Then you may have investors that care about short-term, liquid financial returns, which is not appropriate for venture or what you're building. So always take that into consideration. With respect to my own background, I was lucky to have had a lot of different hats in life. I was technical first, computer programmer since a very young age, then a scientist. Then I traded my white coat for a black coat and became a management consultant and an angel investor, and have since, in the past, over a decade, invested in about 35 health tech companies around the world, often at very early stages. So that's my context. So what do investors generally look for? Everyone has seen this. We don't necessarily need to go through this. I think Dean also had listed some of these critical success factors. I think there are some nuances, however, when you think about the life sciences and healthcare. When we say we're looking for a team, well, you need a clinical, technical emphasis on the team. You need to make sure that you've got some good adult supervision, a rock star advisory board. On the commercialization side, you need evidence, because if you don't have evidence, people's lives are at stake here. You need to understand how the stakeholder journey works, because, of course, in healthcare, it's one of those really, really weird industries where the customer isn't necessarily the beneficiary, nor is it necessarily the decision maker or the payer. So, you've got this really weird splitting of roles that you don't generally see in other industries. And then, of course, because you're dealing with lives, regulatory really matters. And then with the go-to-market, similarly, because of this weird split stakeholder thing that you've got, and you've got also different financing models and different ways healthcare systems are structured, usually pathway dependent. You have to think about how you're going to get distribution, how people are going to pay for it, and who you're going to do this with, because it's really hard as a small startup to try to take on the world. So some non-obvious considerations. I think we all know from Theranos that fake it till you make it is highly frowned upon. Again, people's lives are at stake, so that's really, really important. The other thing is, generally, when you have a strategic investor on your cap table, in some sectors, that's considered a bad thing as a blocker. So if you structure things carefully and intelligently enough, actually having multiple strategics on your cap table can be a good thing. B2B is actually the preferred model, at least in our space. Consumers are fickle and they don't like to pay for anything in healthcare generally. And, and some of these other points I had already talked about. Now, you guys are starting out from scratch, so the early stage considerations, I think, are really, really important, and you've probably been told this time and time again that team is the most important thing. So I've only decided to re-emphasize that further. I think the nice thing about a seed stage is that you're kind of expected to screw up a few times. So it's good to think about how you can pivot, contingency plans B, C, D, E, and F. I disagree wholeheartedly with Arnold Schwarzenegger when he says plan B is make sure you don't fail plan A. I think there's a little bit of survivorship bias in that. Yes, you'll have 1 out of 100,000 succeed spectacularly with that strategy, but I don't like those odds. Cash burn versus fundable milestones, I think it's really important to look at how much you plan on spending versus where you plan on getting, and having a really tight control on that is really important, especially at the early stages, because if you have not reached the fundable milestone by the time you run out of cash at the seed stage, you're probably dead. And then the other thing is, because you're super early, you don't have anything, your ability to tell a story, why you're doing this, why this is more important than something else you could be doing with your time, super important. So non-obvious considerations, broken cap tables, naively restricted covenants. A lot of early investors kind of screw up companies, so just be really careful there. And then the other thing we always like to think about at the seed stage is how much value we can add. So without further ado, I'll go into some quick do's and don'ts, and I think my timekeeper will keep me honest here. So do your homework. I reject 75% of pitches because they're totally irrelevant to what I do. You see my my little LinkedIn blurb, investing in seed stage health tech companies for emerging markets. So, okay, raising a C round, whoops. Yeah, doing something in fintech and blockchain, whoops. And that ruins it for everyone else because, you know, I'm wasting my time ignoring these emails and I could be replying to yours. You know, so homework is really, really important. Investor sourcing channels, understanding what the investor focuses on, where they are in their life cycle, because sometimes they might not be investing anymore or they might look for short-term stuff. What else they've invested in is a really good indicator of whether you fit or not. And then personality and working style is hard if you've not met them, but you can kind of see how they interact with the world. Do think big. So I'm a venture capitalist, which means I need 100x on my investment. So, you know, there are so many things I can invest in. I see 2,000 companies a year, so why should I invest in yours in particular? So it has to be something that is really a good fit, really can do something world-shaking, impact millions of lives, and, you know, if you want to talk to me, then we have to understand we have a fit there. Otherwise, you know, your time is important, my time is important, so let's not, you know, convince me that I need to change my thesis, right? I think building trust is super important. You know, trust can be built or it can be borrowed or conferred. And, you know, trust can be personal or trust can be in the proposition. So just think about where you are actually fitting in that quadrant. And then the other thing I like to show is that, you know, an investment decision is where you have trust and relevance working in your favor. So if I trust you with my life, I don't care what you're working on, I'm going to invest in you, right? If you've cured cancer, you know, definitively, cheaply, and accessibly, I don't care who you are. I'll just invest in that thing. Those are extremes. That virtually never happens. So it has to be somewhere along that spectrum. Now, the thing about relevance is that if our starting point, sorry, is that a pointer? No pointers. No. Oh. Laser. Yeah, it's not. Here we go. All right, so if our starting point is really, really early, like let's say you're doing something about, I don't know, biliohepatocellular carcinoma, right? And I know nothing about it. I probably didn't even say that right for the doctors in the room. It's going to take a really long time for you to educate me on why I should care about that. So that might not be a really good starting point. Or if you, I don't know, if we're like, I don't know, waiting for the line to go to the washroom and you try to pitch me your startup when I have a full bladder and I'm thinking about other things, that's probably not a good place to start from trust. So timing, so trust can be built with time and social proof. Relevance can be built with education, but just understand that, you know, it should be close to this decision point, if anything. It's really, really hard if we're starting from too far away. And the last do have a plan. It'd be, you know, if I had a nickel for every time someone showed up unprepared for a meeting, it's like, what do you do? It's like, why are we here? So, you know, there are materials. You can share materials with people. You can make sure your materials are set, understanding the concept of sales funnels and prioritizing, you know, who is a likelier fit versus a less likelier fit. The other thing is this is a marathon, not a sprint. Again, I think 1 million people will tell you this during your journey. So it's about discipline, not focus. So discipline is the ability to focus on things you hate doing. And generally, asking for money, most people hate doing. And if you love asking for money and you're really good at it, you're probably going to jail at some point in your life. So organization is also really good. Have your stuff together and understand who is doing what. So nothing pisses me off more than when I have 3 people from the same startup pitching me with 3 different versions of their pitch within 3 days. Yeah, so please make sure you guys are coordinated internally. All right, so speaking of pitching, on the don'ts, don't pitch, right? I have the attention span of a goldfish, and you will find that most investors have ADHD, which is why they are investors and not building a startup, right? So you know, you'll lose me if I have to sit still for more than 2 minutes. So we have to have a conversation. We have to have a conversation. It's not like you're sitting there and you're like, oh man, I got through my pitch and I wasn't interrupted once. You failed. Chances are everyone in the room is like on their phones, you know, checking what, you know, Trump did next on Twitter because it's really interesting geopolitical times right now, probably more interesting than your startup pitch. So make sure it's a conversation, right? don't mislead. So we talked about Theranos earlier. You notice on our advisory board we have both we have both Tyler and Erica on our advisory board. This is really important to us, right? Human lives are at stake. Serious money is at stake. Don't mess around, right? This is not B2B SaaS and tech. You know, these are people's lives. And we talk. Investors, oh, do we talk? We have nothing better to do than to talk. So yeah, please be honest. It's okay to paint a vision of what the future may look like, but don't claim that the future's here already, right? Number 3, don't use, oh man, again, if I had a nickel for every time, it's like, oh, we're closing in a week, you know, it's come in or never, and it's like, yeah, so 3 months later, so you guys close yet? You've lost all legitimacy. So please, pressure tactics don't work. If you've got a real reason to sense some urgency, then, you know, do feel free to convey that. But, you know, most investors do march to their own beat, especially in this environment. So that's really important. And last, you know, you're going to get punched in the face 100 times, maybe 200 times. And most of the time it's not you. It's just not a fit. You know, it's like trying to, I don't know, it's trying to, I'm trying to think of a humorous analogy, but it's escaping me Saturday afternoon. But basically, you know, investors have a very clear thesis on what they do and what they don't do, unless you're family offices, which seem to be a little esoteric. You know, just make sure that you've done your best to try to figure out whether you're a fit or not. And sometimes there are things that remain unwritten that, you know, they just don't invest in, but they don't publish. For example, like not investing in people under 30. They're never going to put that online, but maybe it's something they just have as a rule. So again, sometimes it's not you, it's them. And so yeah, that's it. Thank you guys. I think we have 2 minutes for questions.
Any questions for Dr. Joseph, anyone? Questions?
Please don't be shy.
Yes, we have one question.
All right.
I think my question would be very quick. Are you interested in pre-seed investments?
Sorry?
Are you also interested in pre-seed investments?
Yeah, we've been the first check of companies. We've also spun out things of universities. Don't recommend it. It's really hard. It takes a year. But yeah, totally.
Okay, thank you.
Any other questions? Nope, if not, you're shy. It's okay. You can always approach him later on during the lunch networking session. If not, round of applause for Dr. Joseph, everybody. Thank you so much. Thank you. Oh, hold on. Let us switch the slides. All right, now for our final segment of the day, we have with us Mr. Julian Petrescu, Business Development Representative of InterSystems. Now in this session, he's going to demonstrate to you how to leverage on InterSystems Iris Vector Search, along with some inspiring examples. So please put your hands together to welcome Mr. Julian Petrescu.
Good afternoon, everybody. Very happy to be here on campus and see so many health tech enthusiasts, and curious to see what will come out of this, but also I realize I'm between you and lunch, so I'll try to make this very quick. So InterSystems, here you can see some of the details that Dean already mentioned. This is where you can scan to get some details about the quick start, more details about our hackathon. And as Dean said earlier, we do quite a few of this around the world with the major universities such as MIT, Stanford, Berkeley, as well as in Europe. And we've seen numerous innovative projects springing out of this event since 2021. So more than 150 projects and 5,000 developers involved. And we're happy to be, for the first time here at NUHS in Singapore, to attend this hackathon and see how the participants can align with the themes of the hackathon, so value-based care and silver generation, using our vector search technology that I'll be talking about next. InterSystems, Dean already mentioned, we're a healthcare data platform company. We have a number of products for the healthcare industry. The Iris for Health database platform that I'll be talking about next. on which we built our own products for the industry, such as HealthShare, which is a health information exchange deployed around the world, Tracker, an electronic medical record system widely deployed around the world, and with the largest install base here in Southeast Asia, and our Data Fabric studio for supply chain, finance, and healthcare. So this is a business slide. I will not talk about all of it, but I'll just focus on some features of our platform. So this shows our database engine, our data platform. So it is a multimodal database engine. What that means is you can access and store data in different formats: relational, document, object-oriented, multidimensional, columnar, and vector, which I'll talk about because this is the subject of our challenge. As well as interoperability. What does interoperability mean? The ability to connect to external systems such as medical devices, trackers, cloud services, and so on and so forth. So all of these are part of the same platform. You have data storage, data access, and ability to connect to external systems in one platform without the need to combine this together. So again, interoperability gives you ability to compose business services, to connect to external systems using connector architecture. And specifically for healthcare, we support all of the healthcare protocols that you find in a hospital, for example, such as HL7, to connect medical devices, such as FHIR, which is typically for APIs, and so on and so forth. So all of this are built into the platform that we hope you will use in this hackathon. And you can deploy in the cloud, hybrid, or on premises. So essentially, again, our data platform, Iris Data Platform, provides data storage, data acquisition, data transformation, support for healthcare protocols, and through the vector search capability that I'll be referring to next, we provide support for generative AI, and again, with a strong focus on the healthcare industry. So what is this vector search and why is it important? This is a largely technical audience, I would expect, so don't need to talk in too much detail. You're already very familiar with this. But essentially, generative AI is a subset of deep learning, which itself is a subset of machine learning and artificial intelligence. And generative AI relies on large language models as well as vector search. Why is vector search important? Because it's related concept of retrieval augmented generation. Large language models hallucinate. So a way to avoid this and a way to focus them, to ground them, is to provide access to specific relevant data sources. And that's what RAG does. So RAG allows you to restrict the prompt that's sent to the large language model, so the one that will actually generate the response to a specific data set, to a specific verified data set. So in healthcare, for example, if you want to have medical information that's verified, you would use a medical specific data set, and you would use this RAG technology with vector search to make sure that the response is correct and it's not a hallucination. In healthcare, hallucinations would be particularly bad, of course. So vector search is what enables RAG. It essentially represents data, it chunks data in and represents it as numeric vectors, which enables indexing and searching quickly over this representations of content. Content can be images, documents, audio, and so on and so forth, multimodal. And it's then represented as vectors, and this is what enables this quick searching of data. This is what this looks like in our database engine. So again, it's a SQL statement with support for vector search and how the data is mapped to vectors and so on and so forth. Again, you'll see this if you look at the instructions of for our platform. And at the same time, when you use Iris, when you use our data platform, you have access to all of the other data storage and access paradigms. So you can collect, extract data as objects in SQL format and so on and so forth, key value. So all of those are available on one single platform. So this is, again, what the framework would look like. This is what solutions built using a vector search on our platform look like. I was having a discussion just the other day with some of our partners in Australia who are actually building real-life solutions for healthcare using the features of our platform. And this is what the typical flow would look like. So this is kind of a schema of the process I described earlier. So we have, I don't know if you can see here, but we have a GitHub repository that we created for this event. So if you go to this GitHub repository, you will see some examples, some sample projects that show you how to actually implement RAG with a vector search using some additional frameworks such as LangChain and Llama Index that you may be familiar with. If not, you can find additional documentation there. So there's 3 demo projects that show you how you can provide additional context, look up references to identify quality, which is good or bad, of information, how to summarize text, how to provide response to a question, and so on and so forth, using this open source frameworks in the context of Iris. So here are some of the learning materials you can find on our site. Some videos. We have a lot of video section on our developer channel about AI and how it's used in the context of Iris. And we have a developer community, which itself is powered by the vector search in our platform, so you can ask natural language questions there. This is the link for it. And yeah, so this is again some of the information about the resources you can find, the quick starts, developer community, and we will actually have a workshop, which I believe is on the 20th of this month, where we will provide all the support and all the the learning paths to support you in this hackathon. So with that being said, if there are any questions, I'll be here. Otherwise, I'll be around. So thank you, and looking forward to see what you develop.
All right, thank you so much, Mr. Julian. Now, be reminded that they do have a booth outside, so if you have any questions during the lunch networking session, feel free to approach them, all right? Thank you so much, Mr. Julian. All right, and with that, we have come to the end of our program today, but before you go, can we all take a group photo, please? Please gather in the middle, all right? Please compact in the middle, face the stage. We're going to take a group photo. Let's all stand up. All right, let's all stand up. Squeeze in the middle. If our speakers for today are still around, can you please join us at the front of the stage? If not, the rest of you, please compact. Okay.
They really compact.
Yes. All right, ready, everybody? Squeeze.
Yeah.
Smile for the camera. Say cheese. All right, 1, 2, 3, health hack. 1, 2, 3, health hack. All right, thank you so much. Ladies and gentlemen, you've been a wonderful audience. Up next, of course, we have our lunch networking sessions, but remember to collect your event t-shirt. It's outside on a first-come, first-served basis. We also have event swag for you to collect. Please remember to do so, and if you are looking for teams, or if you're a team, you're looking for members, please remember to check out the networking board outside and paste your post-it note with your details. Otherwise, thank you for joining us. We look forward to seeing all your submissions. Have a good day. Bye-bye.